Hello, good morning, sir. From Laos. How are you today? Can you hear me, sir? Can you on the camera, sir?
Selamat pagi.
Hello, good morning, sir. From Savanakat College, Laos. Can you hear me, sir?
And hello, good morning, everybody. Yes, we can hear you nicely. Thank you.
Thank you, sir. Baik, kepada seluruh peserta, kita akan memulai seminar internasional kita pada pagi hari ini. Jadi kami mohon kepada seluruh peserta yang hadir melalui virtual Zoom meetings untuk tidak melakukan kegiatan yang lain dan mengikuti kegiatan ini.
Good morning, ladies and gentlemen. Before we start our agenda for today, we inform to all of you don't make activity out of our agenda for today. Thank you.
Oke. Assalamualaikum warahmatullahi wabarakatuh.
Good morning, ladies and gentlemen.
I am Retna Wahyuni.
And Destin Murniantin Raha.
It is a wonderful and precious chance for us to be master of ceremony in this beautiful morning in Sekolah Tinggi Ilmu Kesehatan Mitra Husada Medan on Thursday, July 14, 2022 in our big event, the second Mitra Husada Health International Conference, Medan, Indonesia.
Praise and gratitude to God Almighty, because only with His permission on the day we can attend in virtual Zoom meeting in the second Mitra Husada Health International Conference with the theme, The Role of Health Workers to Improve Health Status and Support Well-being for All Age. On 14 until 15 July 2020 in Sekolah Tinggi Ilmu Kesehatan Mitra Husada Medan, Medan, Indonesia.
We say thank you and welcome the Honorable Madam Professor Zahra Saad MSc BSc Education SRN SCM from MIHHICo University, Malaysia. Welcome, Madam. Maybe she will join with us later.
The Honorable Mr. Dr. Punimit as Vice Director and Dr. Honesafa, Dr. Vinay Chasampo from Savanakat College of Health Science, Laos. Welcome, sir.
The Honorable Mr. Dr. Sidaruda Zivali, MBBS MD from London School of Hygiene and Tropical Medicine, London, and he will join us later.
The Honorable Madam Agita Pasaribu SH, LLB MA from UNICEF and also is a founder of Bullet of Indonesia. Welcome, Madam, and she will join with us in the next time.
And the Honorable the Chief of Stikes Mitra Husada Medan, Madam Dr. Siti Nurmawan Sinaga SKM MKes. Welcome, Madam.
We say thank you for all the participants who present in this international conference of second Mitra Husada Health International Conference Medan, Indonesia.
Okay, before we start our agenda for today, we inform to all of you that our agenda during today's were the first day opening and presentation from the keynote speakers and the panel presentation, and in the last day, there is oral presentation and closing the second Mitra Husada International Conference. Ladies and gentlemen, we will read our agenda for today. That is welcoming and greetings, opening prayer, national anthem and march Stikes Mitra Husada Medan, the committee chairman report, traditional dance, opening ceremonial and welcoming speech from the chief of Stikes Mitra Husada Medan, and we'll continue the keynote speaker and panel presentation, and the last is closing.
In our agenda going well and God bless, we are praying led by Ashari Sarai. Time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Let's all bow our hand for a moment. Pray to God Allah Subhanahu wa Ta'ala so that our international conference can be precious to all of us. I will lead the way based on teaching of Islam, and who are not Muslim, you are pleased to pray according to your beliefs. Alhamdulillahi Rabbil Alamin. Wassalatu wassalamu ala asrafil anbiya'i wal mursalin wa ala alihi wa sahbihi azamain. Oh Allah, Tuesday July 2022 in the beautiful place and Zoom meeting. We gather here to bring about on the second Mitra Husada Health International Conference. The theme is the role of health worker to improve health status and support well-being for all age. Make this international conference as useful chance as medium for sharing useful ideas, knowledge, and experience of scholar, researchers, and students of various disciplines. Oh Allah, let us make to institute health since Mitra Husada Medan, a campus that is always useful and highly competitive, and make a country alabatun tayyibatun warhabun ghafur rahim. Oh Allah, you are the one who fulfill our dua. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Alhamdulillah rabbil alamin. Assalamualaikum warahmatullahi wabarakatuh.
Thank you for the lead this player.
The next agenda is singing national anthem, Indonesia Raya and March Stikes Mitra Husada Medan. To the all audience, we invite to stand up, please.
continue singing MIHHICo's Mitra Husada Medan.
To the audience, sit back, please.
Well, we are entered to the next agenda. The committee report international conference to Mr. Zulkarnain Batubara and home time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. I hope all of us in good condition for today. The first, the Honorable Professor Jahra Saad from the Mahsa University. And then the Honorable Dr. Funimit as Vice Director and Dr. Konsapan and Mr. Pinay Konsopot from the Sapanaket, Laos, and the Honorable Dr. Sidaruta Tipali, MBBS MD from London School of Hygiene and Tropical Medicine, and the Honorable Mrs. Agita Pasaribu, SHLB, MA from the Buliet, Indonesia, and the last, the Honorable the Chief of Dr. Siti Numawan Sinaga, SKM MKes, from Sekolah Tinggi Ilmu Kesehatan Medan, Indonesia, and all of the speaker and participant of the conference that I love. First of all, thanks to Allah Subhanahu wa Ta'ala who has given us mercy and blessing, so we can gather here for the following, the second Mitra Husada Medan Health International Conference in 2022. In the meeting and organized by Sekolah Tinggi Ilmu Kesehatan Mitra Husada Medan. Salawat and salam to our Prophet Muhammad SAW, who has bring us from the darkness to the brightness period. And the theme that we raise in this international conference is the role of health worker to improve health status and support well-being for all ages. The correlation with the theme, we present four speakers as the mainly speaker, namely the keynote speaker 1, Dr. Punimit as a Vice Director, and Dr. Konsapan and Mr. Pinay, and the keynote speaker 2, Professor Zahra Saad from the Mahsa University, Malaysia. And the keynote speaker 3, Dr. Sidarota Sipali, MBS, and the last speaker, Mrs. Agita Pasaribu, MA from Bulit, Indonesia. Besides that, we have also the oral presenter and for the all Ilmiah poster for various institutions and several countries. And this international conference can be implemented because the help of participation on this conference, especially to Mitra Husada Medan Foundation, Mr. Imran Subakti, MM, and all of the staff as well as the sponsor, and participate in international activities. We cannot mention one by one. We also extend to highest appreciation to all committee members who have worked hard toward success of this conference. And the last, we realize that there are still many shortcomings of organizing this seminar, both in the terms of event of presentation, administrative service, and the limited facilities that we hope apologize profusely. Finally, I hope that all conference participants who attend will benefit greatly from this conference. And the last I say, good morning and Assalamualaikum warahmatullahi wabarakatuh.
Thank you for your report, Mr.
Okay, before we continue our agenda, welcome to Professor Madam Zahra Saad from Mahsa University. Hello, Madam. Hello, Madam Zahra. You still in?
Hello.
Okay.
Thank you. Able to join today. Assalamualaikum warahmatullahi wabarakatuh, and good morning to all.
Okay, good morning, Madam. The next agenda is traditional dance with the title Tortor, which is the traditional dance is a welcoming to all of us. Let's enjoy. thank you to the personnel of the UNIF student of Stikes Mitra Husada Medan.
The next agenda, welcoming speech and opening the second Mitra Husada Health International Conference led by the Chief of Stikes Mitra Husada Medan to Madam Dr. Siti Nurmawan Sinaga SKM MKes. Time is yours.
Good morning, ladies and gentlemen. My name is Dr. Siti Nurmawan Sinaga. As the Chief of Stikes Sekolah Tinggi Ilmu Kesehatan Mitra Husada Medan, Indonesia. The Honorable Professor Zahra Saad from Masa University, Malaysia, and also Dean Faculty of Nursing and Midwifery. Welcome, Professor. The Honorable Dr. Son Kanton Sing Paun Pet, PhD, from Sapanaket Laos College of Health Science, now represented by Dr. Punimit as Vice Director and Dr. Konesapan and Mr. Pinay Kansompon. Welcome. The Honorable Dr. Sidaharuda Sifali, MBBS, MD, London School of Hygiene and Tropical Medicine, and also as Assistant Professor Epidemiology. The Honorable Miss Agita Pasaribu, SH LBB MA, from UNICEF and also as founder of Build Aid Indonesia. And also the lecturer, speaker, and seminar participants, especially participants of oral presentation, the Honorable Professor Dr. Anda Ida Justina MSc from North Sumatra University, and also Dean of Facultas Public Health, and the Honorable Dr. Pikarwin Juska from North Sumatra University. Welcome, Prof. First of all, let's say thank to our God who has given us happiness and health so we can meet the participate in the Zoom and YouTube in this special event. We are proudly present webinar international second Mitra Husada Health International Conference 2022 with the theme, the role of health workers in improved health status and support well-being for all ages. The conference Stikes Mitra Husada Medan is a very important activity because it is a forum to lecture students, scientists, participationers, both from domestic and abroad to share and discuss to improve health status. The theme at the conference was focus of all these targets include community nutrition, mental health, maternity and children health, elderly health, research development, innovation and technology in health, teenager health, and complementary therapy. The development of the health sector of the SDGs is highly dependent of the activity rule all stakeholders, both central and local governance, parliaments, the business world, and mass media, social institution, professional and academic organization, development partners, and the united and national. The biggest challenge in implementing the sustainable development agenda in Indonesia is the reformulation of the integrated development concept and the placement of health as a series of development management process and include input, process, output, outcome, and impact of development, as well as understanding together to sustainable of health development the must in implemented together in the 5.0 era. Based on this challenge, this conference is one of activities in achieving the vision of Stikes Mitra Husada Medan, namely realizing Stikes Mitra Husada Medan is a center for science and technology development in the field of health and excellent service with high integrity in competitiveness in the national level in 2030. And we hope Stikes Mitra Husada Medan CPT will able to produce health workers in improve the health status of people of all ages. On this occasion, we are very proud because of the enthusiasm of the participants of the conference, because until the last day of registration, we are as many as 8,000 participants who registered from a target of only 2,000 participants. For the Stikes Mitra Husada Medan will be commit the providing the best service during the webinar to all the participants and colleagues involved in the conference. Once again, welcome to the second Mitra Husada Health International Conference 2022. Thank you very much. Thank you.
Thank you for a nice welcoming speech and opening this event. Ladies and gentlemen, now we are entered to the keynote speaker's presentation. We inform to you, every keynote speaker's already presentation, we have time to giving a question and answering time. The first, the matter from Mr. Vinay Chasampu with the title, Way to Zero Malaria Elimination in Law PDR. We're waiting for a presenter to prepare. I want to read the curriculum vitae from the Mr. Excuse me. Hello, Mr. Vinay. Hello, Mr. Vinay. Are you there?
Yes, I'm here. And can I share my slides?
Yes. Before that, I want to read your curriculum vitae before.
Okay. Thank you.
Thank you, sir. Well, ladies and gentlemen, Mr. Vinay, his name is Mr. Vinay Chamsompo, and then he birth date of 24 on April 9, 1993. Current occupation, pharmacist at Savannakhet Medical and Diagnostic Center, and just instructor at Savannakhet College of Health Science, country of residence Laos and nationalist Laos. Okay, Mister, can we start our presentation for today?
And sorry, can you unmute? Can you unmute for CHS Savannakhet, please?
Okay, Mister.
Can you hear me?
Yes, of course.
Okay. Okay, let me share my slide. Okay. Yes.
Okay, Mister.
Okay. Good morning, ladies and gentlemen. Firstly, let me thank for having me here today. My name is Vinay Chansampu on behalf of Savannakhet College of Health Sciences. Here with us is Dr. Punimit Wongwat, the Vice Director. Yes. And Mr. Thongdam Sisawat, Chief of Administration Sector. Ms. Manimon Chulabut, Chief of Academic Affairs, and Dr. Khonsawan Latanawong, Chief of Student Bottom Rooms. It's an honor to have the opportunity to present and exchange towards how to empower our health system. In my presentation, I would like to share the health situations in Lao PDR, particularly malaria and how we have eliminated it in our country. Okay. In my presentations, I will focus on 4 major contents: overview, problems, strategies, and conclusions. Lao PDR is located in Southeast Asia and a landlocked country with an estimated population of 7 million people, 18 provinces, and share with 5 international borders. The northern part is bordered with Myanmar and China. Vietnam is to the east and Cambodia to the southeast. Thailand to the west and southeast. The majority of Lao population, roughly 63%, lives in rural areas. Although Lao public health has dealt with the surge of the COVID-19 pandemic in recent years, healthcare workers have also faced numerous diseases, one of which is malaria, which has been one of the main issues in Lao PDR so far. The majority of the country's high transmission areas are mountainous, forestry districts, and in the south, where the vast majority of people work in industry associated to forests. Here on the slide, you can see that the red area is in the south of Laos, which is the high transmission areas. And malaria had been national issue of Lao PDR so far. In December 2011, Lao PDR had an eruption of malaria that threatens the steady progress made against the disease. The outbreaks in the south of the country led to the sharp rise of confirmed cases and deaths. There was a
Excuse me, mister. Any problem there?
Okay, can you see my slide?
No, no, mister. We can see your slide, mister.
Okay, sorry, let me move.
Excuse me, mister. We can share from here. Can we help you to share from here, mister?
Yes, yes, please.
Thank you, mister.
Okay, please, sorry for interruptions. I will place next the slide, please. Okay, and the next slide, please. Okay, thanks. Lao PDR had an eruption of malaria that threatened the steady progress made against the disease. The outbreaks in the south of Laos led to the sharp rise of confirmed cases and deaths. There was a marked rise, roughly 40,000 malaria cases in 2012 as a result of the acute malaria outbreak in 2011. However, in 2014, the cases were slightly increased, but the fatality had decreased significantly, roughly to 4 cases. Afterward, both infected and fatality trends have remarkably gone down since then. In 2020, beside the outbreak of COVID-19, the rise of drug resistance for treating malaria are major worldwide concerns, especially amidst the Great Mekong subregions. Nonetheless, since 2020, it saw an all-time low of roughly 3,000 cases. In 2021, there were only a fatality case. Okay, next please. Okay, now I will present about health system in Lao PDR. In Lao PDR, we have administration levels and service delivery. And the Ministry of Health is the central, and they will manage Department of Health, and then Department of Health will monitor District Health Office. About service delivery sites, Central Hospital is managed by Ministry of Health. Provincial Hospital is managed by Department of Health. District Hospital and Health Center are monitored by District Health Office. And for transfer and data efficiency, I will present about malaria surveillance process diagram briefly. The data transfer process. Next, please. Sorry. Okay, thank you. The data transfer process is for reporting information related to malaria. Including patients, medical devices, or medicine, etc. Briefly speaking, the main collected data sector is district health information software tool, or we call it DHIS2. The village health volunteers will report case information to health center. Afterward, the health center will transfer to district anti-malaria sector, okay, which will directly send to district health information software. Besides health center, public, private, mixed sector, and district hospital have to transfer information to district anti-malaria sector either. Meanwhile, provincial hospital could transfer data to provincial anti-malaria center, which will send directly to DHIS2. In addition, Center of Malariology and Central Hospital can directly transfer their data to DHIS2 directly. Okay, next please. And in the nutshell, health professionals have played a critical role in responding to and preventing malaria in both urban and rural areas. This can extremely support Lao PDR in order to achieve this objective. Although there are numerous problems that we have to solve, but these are four main issues that we have to intensively focus on. I'd like to discuss in more depth about each problem. The first one is healthcare delivery in the community. We have faced serious lack of human resources, particularly, next please. Next please. Okay, next slide please. Okay, thanks. Healthcare delivery in community, we have faced seriously lack of human resources, particularly in healthcare provider. The main network for healthcare provisions remains the public system with government-owned and managed provincial and district hospitals and health centers. A low utilizations of health services, particularly in primary healthcare facilities. There are also problems with the distributions of health staff, particularly in deployment of staff to remote areas. Next, please. The current approaches may still fail to capture malaria surveillance data on malaria in mobile and migrant populations for a number of reasons, including language barriers. Since there are diverse ethnicities in Laos which use different languages, legality status of work activities or residents, access to health facilities, and using of information and technologies. Okay, next please. And this is one of the main problems. The therapeutic efficacies of artemether, lumefantrine, or some one called it coartem, the first line treatment regimen, has been ineffective and cure rates have remained high since 2005, especially on the southern provinces. This confirmed the emergence of artemisinin resistance in the south of Laos. These results come from therapeutic efficacy studies or TES, where patients who are enrolled are those that can be followed up serially over the course of treatment and beyond for blood tests. The proportions of patients with delayed parasite clearance times are believed to be similar or even high among the highly mobile populations who are excluded from the inclusion criteria of TES. If scaled up nationally, this could be the single most important factor for reducing transmission among returning mobile workers from the south, many of whom have repeated infection in even year. Okay, next please. Okay, as I mentioned before about multi and ethnicity in Laos, in some minor ethnic groups, they still have unique cultural beliefs and practices which are somewhat a barrier to access to healthcare systems. For instance, if their family members have convulsions because of high fever, they would take them to rescue salmon instead of healthcare workers, since they believe that their members are obsessed by ghosts. Moreover, the worksite areas are generally remote and lack access to health, education, and basic services. Thus, implementations and enforcement remain a challenge, with affected workers likely to be illiterate, belong to an ethnic minority group, and live in poorest households. Okay, next please. Next please. Okay, according to prevent, control, and eliminate malaria, both contribute and benefit from sustainable development. Next please. Next please. Okay, the objectives of reducing the disease burden and eliminating malaria are essentially linked to the most of the sustainable development goals and are ensure healthy lives and promote well-being for all ages. And its target 3.3 is by 2030, and the epidemics of AIDS, tuberculosis, malaria, and neglected tropical diseases, combat hepatitis, waterborne diseases, and other communicable diseases, intro to SDG 3. Next, please. Therefore, our Ministry of Public Health will continue to focus on providing as technically assistance to strengthen the national malaria program's surveillance system to generate and use strategic information for the detections, responding, and reporting to each malaria case. Second, monitoring treatment outcomes of anti-malarial drugs, updating national treatment policies, improving national programs, capacity and supply chain management and quality laboratory diagnosis, improving access to anti-malaria drugs and other malaria services for all patients, including vulnerable populations such as migrant workers and ethnic communities, financial support for volunteers and patients. Next, please. However, and most of Great Mekong sub-regions are moving on to the last phase of the effort to eradicate malaria. The Lao PDR government committed to eliminate malaria by 2030. As you can see on the slides, Thailand, 80% of Thailand will be malaria-free by 2020. Vietnam reduced malaria morbidity to below 0.15 per 1,000 populations. And that is one of the phase that we are going to achieve. Next, please. Okay, Lao PDR will have achieved national elimination. The timelines and geographic targets for elimination are followed by 3 phases. Since 2015, next please. Okay, since 2015, we hadn't implied this strategy. As you can see on the slide, the contagious rate was still high and concentrated, especially in the south. Okay, next please. In the first phase, which lasted from 2016 to 2020, it was intended to stop malaria outbreaks and lessen the drug resistance in the southern provinces, besides eradicating Plasmodium and falciparum in the northern and southern provinces. Okay, next please. The second phase of eradicating PF or Plasmodium falciparum across the nations and all malaria vectors in the 13 northern provinces will take place in 2021 to 2025. Moreover, bringing Plasmodium vivax or PV to less than 1 in 1,000 in the southern provinces in 2025, prevent reinfections in areas that have been cleaned. Okay, next please. And the final phase is 2026 to 2030 is the third phase. The aim is to eliminate malaria throughout the country, prevent reinfections, and begin with the free of malaria status. Okay, next please. So to complete this achievement, we have to execution. In the upcoming slides, I will focus on our current responsibility, which is the second phase. The goal is from 2021 to 2025, eliminate PF throughout country and eliminate PV in the northern provinces. Okay, next please. Continue to deliver. We will continue to deliver high quality care and diagnostic, intensify blood testing to meet the national objective, and provide high quality care to the entire country. Make sure that all suspected cases of malaria are recognized and that the annual malaria blood exam level is at least 10% in transmission areas and 3% in clean areas. And the second is treat PF or Plasmodium falciparum infections with artemisinin-based combinations therapy or ACT and primaquine at a low dose once. Intensively monitor artemisinin resistance by conducting monitoring anti-malaria drug efficacy practice or TES. We will follow prospective evaluations of patients' clinical and parasitology responses to directly observe treatment for uncomplicated malaria. And another one is supervised drug administration where possible to help to ensure adherence. Strengthen village malaria workers to take responsible to integrating community case management, or we call it ICCM. Is the provisions of treatment for malaria by community health workers, and will still remain public-private mix strategy to increase the access to rapid diagnostic tests and artemisinin-based combination therapy, or ACT, improve quality of care, and collect routine malaria data from the private sector in the transmission areas, and adjust some responsibilities of PPM in claims areas. Next, please. Okay. So the role of healthcare workers in conclusions is assist the provincial and district malaria programs to effective implement, monitor, and supervise of all related interventions for the malaria eliminations accelerations project. This includes supporting the preparations and launching of the projects, conducting demographic census in the field, supporting the implementations of targeted drug administrations in select villages, supporting the field operations for providing intermittent preventive therapeutic even for forest goal, conducting active fever screening in select villages, and data collection and systematic reporting related to the project. Effectively support the rollout out the training and monitoring and evaluation related to the projects. We still improve the capacity of provincial and district malaria staffs to regularly and systematically analyze and interpret monthly malaria disease surveillance data in the malaria information system, as well as the project data relating to TDA, AFS to identify and address common programmatic issues. We still assist the provincials and the district malaria staff to build management and operational systems that are based on the project. Participated in the contribute to ongoing World Health Organization Respectful Workplace initiative that encourages trust, responsibility, accountability, mutual and respect, open communications, and where the dignity and diversity of individuals is fully embraced. However, we have been faced numerous challenges, including the lack of human resources, especially in the remote healthcare worker, because of the lack of transportation and delivery paths are still uncomfortable to travel. Patient delivery, particularly in severe or emergency cases, is still the main challenges of our public health sector to overcome. However, we, the healthcare workers, will constantly contribute to improve people's well-being and healthy life of our communities to reach the standard and sustainable development in the long run. Okay, I just like to finish with the words of a famous pediatric surgeon, Charles and Everett Coops, who has said healthcare is vital to all of us some of the time, but public health is vital to all of us all of the time. Okay, thank you for your attention. Now I am happy to answer any questions you might have. Thank you.
Okay, thank you, Mr. Pinay. This is the nice presentation. for you. And next agenda, we will invite about our participant to ask about your presentation. Yes, for the destin, I will invite you to ask for Mr. Pinay, please.
I'm sorry, Mr. Vinay. I will tell you that the moderator for your in this session is Mr. Zulkarnain. And the next, I will give to the Mr. Zulkarnain. To Mr. Zulkarnain, give time to session question. There are 2 sessions, and each question will give in chat room. Now I will give to Mr. Zulkarnain to moderate in this session. Please, Mr.
Okay, thank you, Mrs. Retno. I think this is the nice presentation from the Mr. Pinay, and this is talking about the problem of malaria disease in Laos. And then we will enter the next session from question and answer. We have 2 sessions from question and answer. And from session 1, this is any Destin will ask about your presentation, please. Destin.
Okay, thank you for your time, Mr. For your time that given to me. Thank you, Mr. Vinay, for your presentation. I think your presentation is very good and very nice. We are from Indonesian people also who want to know everything and anything from the Laos because we have a relationship before. And then our colleagues and your colleagues have relationship. Mr. I want to ask you in this in your PowerPoint and then in your presentation that have you tell that the strategy of from the government and then the strategy in your slide I see reduce the disease burdens, eliminate malaria, improve healthy life and ensure well-being. Here I have a question. How if the community in your country, if they are not do what the government make. For example, we have same like in Indonesia, we have so many cultures, so many rules in the community. So that what the strategy have you do to make your community join and then support the government rules to make malaria in low? And then I see in your presentation is a timeline of malaria elimination in 2020 and in 2025, in 2015. Here is your picture is red, and then I see in 2022 there were still hike of level. So that you can explain to us how about your evaluation from the strategy that government or from your presentations, the evaluation from your presentation. Thank you, sir. I give to moderator.
Okay, thank you, Mr. Pinay. You get the point, the question from the Destin, Mr.
Okay, thank you for your questions. As far as I understanding, you have two questions, right? The first one is for cultural belief. Do I understand you right? If you want to know how we cope with the cultural belief in some minority ethnics, now and as I present, that was one of our challenges. However, our government have provide policies to access these groups and to provide their knowledge and improve the understanding of how to self-care and how to keep themselves hygienic. And moreover, we still provide some we call it LLI net or long-lasting insecticide nets for them to prevent them from malaria. And that's one of, but sometimes the language barrier is still our challenges. So we will ask some village volunteers to translate, to be our interpreter, to provide or translate and our understanding to the minority ethnics, and that is. But however, we still difficult to process or evaluate, and this because of the path, the road to go to their village is very difficult. So that take time to solve these problems, and we are ongoing to do that. And for your second questions, can you ask me again, please?
Yes, Mr. For the second question about what is your evaluation about for reducing of malaria disease in your country? What is the evaluation doing for your country about the malaria disease, sir? Mr.
Okay.
Pinay?
And yes, thank you. We have our own indicators for evaluating. The first one is how the infected cases, the number of infected cases is lower or higher, and this is one indicator. The second one is the drug resistance. So the drug resistance, I have to say that our country can't stand do it alone, but we have luckily we have some NGO or non-government organizations to help us. For instance, JICA, the Japanese international organizations, or WHO or UNICEF, to help us to evaluate the drug resistance by they will, if you can see on the slide 25, I have showed that the pictures of some laboratory and tests towards the drug resistance. So if they found that in some patients they use the artemisinin without efficiency, so they will adjust or they will change to another medicine to prevent the resistance. And that is how we cope with the drug resistance. And another indicator is to collect data from help our village volunteers, and they will send the data to the HIS tool to process again. And the deep informations I frankly say that I don't have enough information to show you. So if you have another if you have other or further concerns about this, please email me, and I will ask for further information and provide you later. Okay, thank you.
Yes, Destin, maybe for the add some explanation, maybe, sir. May, sir. Mr. Pinay.
And can you say again, please?
Yes, I think Destin give explanation about the suggestion of malaria disease, sir? May, sir?
And do you mean and explain about malaria or
Like suggestion, sir? In our country, maybe? Yes, sir.
sorry,
I think this
I
is
can't hear
the
you
response
clearly.
from the destined question, sir. Sir?
Sorry, I can't hear you clearly. Can you
Yes.
say it again?
I think this is destined may give response from this question, sir. Give the response. You get the point, sir, about my question?
So you say that, and I have to respond for your question, but what kind of response?
Yes, this is respond about your explanation, sir. Yes, yes, Destin, please, Destin.
Well, thank you, sir, for your explaining to me. From your explanation, I can understand and can make conclusion here. There is now in your country to make malaria in a low and then make it zero. There is now on progress, and then we hope from Indonesian your progress your program will be progress, and then if we can I want to giving same like we do in Sekolah Tinggi Ilmu Kesehatan Mitra Husada Medan. We are unit students in Stikers Mitra Husada Medan already do like a promotion to community to make the problem in Indonesia, especially in our region, North Sumatra Provincial, in low like COVID-19 in 2022 until 2021 last year. Thank you, sir. Thank you for explaining. Thank you. I give to moderator.
Okay, thank you, Destin. Give applause, please. And the next, sir, I think one session have two question, and for the last session have two question again, sir. And we enter the next question. This is from Bintang. Where is the Bintang? Come here, please, in front of our, yes, here.
Okay, thank you for the time given to me. Now I want to ask about part for the first. The question is, how many cases fatality rate of malaria on maternal and neonatal in Laos? And the second question, what is midwifery role to prevent malaria in maternal health in Laos? And their question, in Sustainable Development Goals, they have 70 goals, and goal health and well-being in number 3. Now I want to ask about the strategy. For the first, in Laos, have strategy malaria elimination. They are for the first, reduce the disease burdens, eliminate malaria, improve health life, ensure well-being. And about, we can see in annual parasitic incidents in graphic about per 1,000 population ended from 2011 until 2021 about annual parasitic incidents. And I want to ask about in graphic in 2022 to 2021, it's not experiencing a decline about malaria. How about that? What's wrong about the strategies? Thank you.
Yes, okay. Thank you, Bintang. I think, yes, I think your question is too long, but you must make in short question. So Mr. Pina is understand about your question.
Okay, thank you. Yes, if I understand you right, and your first question is for the cases report in 2021, right? And the last report I have received is we have 3,505 cases infected, and just only one facility case. I mean one death. Yeah. And is it what do you want to know about the first questions?
Yes, sir.
Okay, thank you. And I'm not sure about the second one, but the third one is that you ask about our strategies to cope in 2021 to 2025, right? Okay, if I understand you right, we focus in 5 sections. The first one is strengthen malaria surveillance. The second is sorry.
Yes, sir. I think the second question, this is about the
second question is, what is midwifery role to prevent malaria in maternal health in Laos?
yes, about the role of the midwifery of reduce of malaria in Laos, sir.
I think we don't divide in what midwife do or nurse or doctor do, but we will do everything that can help our community to avoid the infected. So every healthcare workers must do their responsibility the best to help community. So as I mentioned in the presentation, we lack of human resources. So we can't provide midwife or nurse or doctor in rural areas, but we ask for village health volunteers, and we will provide them the knowledge about the healthcare, the primary healthcare to help them work in the rural areas. And so that is our responsibility to cope with this. So, and according to your questions about the midwife, I think in Laos we don't have enough the number of midwife who they deliver only malaria or on COVID, for instance, but we have to, and all healthcare workers have to do the same responsibility. So yes, and okay, thank you.
Yes, how about you, Bintang? You get the point about the answer by Mr. Pinay?
Yes, sir. Thank you about your explain, sir.
Yes, okay. Thank you, sir. This is the answer for the third question. This is from the chat Zoom, sir. This is from the Wahyu Lydia Marpaung from the Diploma 3 of Midwifery Stikes Mitra Husada Medan. The question is, what is the cause of the high prevalence of malaria in Laos, and what is our roles as the health worker in responding to and dealing with this, sir?
Responding and dealing with malaria, right?
Yes, sir.
Currently, as I said, we have to focus on the malaria programs and support the preparation and launching of the projects. And the one of the main challenges is medicine resistance. That is what we concern. But about the malaria situations nowadays, and it's not too serious because we can control it, and the cases now is not too high to be concerned. Yeah. Thank you.
Yes, okay. Thank you, sir. I think this is for the last question from Wita Nancy. Yes, please, Wita Nancy.
Good morning, all of us. Thank you very much for opportunity given to me. I want to ask Mr. Vinay Chansompo, how to increase the capacity of the community in effort to reduce the incident of malaria in Laos, because the attitude and ability of the community affect the success of management of malaria. And what are the challenges for the health system in Laos to management in malaria in Laos? Thank you. Thank you, sir.
Okay, thank you for your questions again. And as I present that the lack of human resources is still our problems, and the priority that we have to cope with this is we will provide the knowledge. We will provide the knowledge, the understanding about the hygienic and healthcare to village volunteers. They don't they are not healthcare workers, but they just the villagers, the normal villagers, but who want to help their community. So we will provide them the knowledge and the understanding about how to keep their health better, how to self-care, and if they know about the health understanding, if they made the emergency case or the severe case, they will know how to contact the healthcare workers directly, and this will reduce the death or the severe case. So my answer is we don't have the truly healthcare worker who works. I mean we limit the number of healthcare workers who work in rural areas, but we will teach we will teach or provide the knowledge for the villagers that they can they can take themselves, they can take care of themselves and their family members. And the other challenge is the cultural beliefs, and that means in some minority ethnicities, they still believe in ghosts or some ritual shaman, so they don't go to the health center, but they will go to the shaman or something that they believe. So and this is also the health access barrier that in some village we can approach to. Yes, and thank you.
Okay, thank you, Mr. Pinay. How about you, Vita? You get the point?
Thanks for answer the Sir Vina Chamsompo. Thank you.
Okay, sir. I think I have the last question. This is from Papua, from June. May I ask once again, sir? Sir, because we have the time, I think this is for the last question from Papua, the province of Western of Indonesia, sir. May, sir? Mr. Pinay?
Yes, sir.
Okay. I will read the question, yes, sir.
Okay.
Yes, this is from Bidantia from Papua. The question is, how do I overcome the problem of the malaria epidemic in Indonesia, especially in pregnant women, sir? You get the point, sir? I think you give the explanation or some of your suggestions, sir, from the reduce of malaria epidemic in Indonesia, sir. Sir? You get the point, sir?
Yes. Thank you for your question. But it is out of my knowledge. So I will ask an professor, and I will give you an answer later. Can I?
Yes, sir. Yes, please, sir.
Okay, and in some transmission areas, we will deeply and closely administer or monitor some pregnancy women, and if they have a high infected, we will provide the artemisinin or coartem to them to take for the treatment. Yeah, but however, we will closely monitor their health and prevent them from the high fever. Yeah. And we will follow the guideline treatments for pregnancy women for and UNFPA. Yeah.
Yes, sir. I think that's enough. And in here, I will get the point of your answer, sir. Yes, I think because the malaria disease interesting discussion, sir. So I think we have more question about the malaria disease, sir. I think if you have the time for the answer, yes, I think maybe in the next session or in the next time, you will answer the question, sir. And then the next session is give a certificate from our campus, sir. This is yes, for symbolis in our Zoom meeting, sir.
Okay.
Yes, this is from the Chief of Sekolah Tinggi Ilmu Kesehatan Mitra Husada Medan by Madam Dr. Siti Numawan Sinaga SKM MKes, sir.
Okay, yes. Thank you so much, and I hope my presentations and my answer is maybe and even is not too good, but I did my best, and I think if you have any further questions or concern, you can email me, and I happily to answer you. And after this, yes, thank you so much for having me here today. Thank you so much.
Yes, thank you, sir. Nice to meet you for today, sir.
Nice to meet you too. Thank you.
Yes. Yes, give applause for us. Yes, I think this is back to the main moderator. For Mrs. Retno, time is yours.
Thank you, Mr. Zulkarnain, who has be the moderator from the speaker, Mr. Dr. Vinay from Laos. The next, we will enter to the next keynote speakers. But before that, I will tell you that today we have 4 keynote speakers, which is the first has done from Dr. Vinay from Laos, and every keynote speakers have about 1 hour to presentation and also have answered the question from the participant. After that, in the session question has 2 session, which is in every session has to have 2 people to give question. Okay. Before we next enter to the next keynote speaker, maybe we can enjoy the dance, video dance from UNIF students stickers Mitra Husada Medan. Let's enjoy. Okay, that's all is traditional dance from students Stikas Mitra Husada Medan. And then now we answer to the next keynote speaker's presentation. The material from Professor Zahra Saad, MSc BSc, Education SRN SCM. And the moderator is Madam Esther Simanullang, STRK BDMKes.
Well, I will tell to you that Madam Esther Simanullang, STRK BDMKes, as a lectures in Stikas Mitra Husada Medan and also continue her study in Lincoln University, Malaysia from doctor's title. To Madam Esther's time is yours.
Good morning. Thank you to the audience. Good morning, Madam Professor Zahra. Very happy for the webinar event. For the second speaker session, we learn from Professor Zahra. Hello, good morning, Prof.
Yeah, good morning. Assalamualaikum. Morning all.
Good morning from Indonesia, from North. Say Horas, Prof.
Alright, yeah. Morning. Good morning.
Present position, Director International Ketans Massa University, have experience 20 years in nursing service, 30 years in nursing education. Excuse me, Prof. We read the CV from Professor Zahra Saad, nationally Malaysian, recent position, Director International Relation Massa University, and then from Dian, Faculty of Nursing and Midwifery Massa University, from Selangor, Malaysia, right, Prof?
Yeah.
We invite our madam to present the material for approximately 45 minutes and will be followed by a 50 minutes discussion question and answer session. Time is your, Prof, to present your material, please. Thank you.
Thank you. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to
Prof.
Can hear? Can you hear?
Yes, Prof.
Yeah, okay. Boleh dengar ya? Can hear? Okay. So this is I would like to take this opportunity to thank the organizing committee, Sekolah Tinggi Ilmu Kesihatan Mitra Husada Medan. This is, I understand, second international webinar. I remember in year 2020, betul kan? 2020, 29, 30th June, I also involved with the first event, first presentation.
Yes, Prof.
Given the opportunity. Thank you for this invitation again. I am happy, my pleasure to share the topic of today. Yeah. Okay. Again, congratulations to the organizing committee, to Mitra Husada Medan.
Thank you,
and
Prof.
all the student performance very talented. Happy to see. I pun ceria tengok ya.
Yeah, Prof.
Okay.
Thank you.
So my presentation based on the topic given. I hope you don't mind. Since we are serumpun, we can share a bit by language, and also I also feel comfortable so to share the bahasa serumpun ya. Okay.
Okay, Prof.
The topic given. This is the bio my CV. The one I sent earlier is the what to say? The presentation. Are you able to to this one? You just want to share with them? You have
Prof.
the one this one I think quickly we can go through, and after that we can go to the topic. And I introduce myself as a humble person. I have my PhD in educational leadership, my master in UUM, my nursing study in Lancaster, higher certificate education, and post basic midwifery. I understand you have midwife also there attending this. That was my photo. I was at the top there, the back on the yang sebelah kiri tu, the next to the person who wearing the spec. Yeah. Okay, next one. So that was me. I was a staff nurse at Sarawak General Hospital, then at Kangar, and at Penang, Bukit Mentajam. Yeah, so that was more than 30-40 years ago. So next one, I would like to share my role as a principal Malacca Nursing College in the ministry, and followed by the principal of the Alostar Nursing College in year 1992. Then I come back to Nursing College at Malacca at 2000 until 2004. Then I joined MASA. Okay. Then when I joined MASA, these are my professional membership and also NGO that I joined. We must be member of the national professional body, like Indonesia also have the Indonesian Nurses Association. I also hold 2 posts for the chairman Malaysian Nurses Association, because at the role of the healthcare professional, we must also be a member of professional body. I hope all the participant, sama ada under jurawat ke, under midwife, under allied health yang lain, you have your own professional body to join, yeah, to join. So I was the Malaysian Nursing Board members for 3 term, also panel curriculum committee. I am also the vice president for the GEM association. GEM meaning that Gerontology of Malaysia, yeah. And chairman of Falah Zikir. So when there's a subject matter specialist, I am now as the nurse with 50 years, but my background more in the gerontology. I have my gerontology course, yeah. So I also joined Global Nursing and Midwifery member, and also in the Malaysian qualification as agency, and also as a chairman for interest group in year 1989. Okay, next one. Okay, these are the activity that I involved in the NGO, and why I would like to show. I hope everyone will able to take part, because when you as a healthcare provider, as a healthcare workers, there's a lot of activity for you. I would like to share proudly to say that these male students, nurses recruited in Malacca Nursing College during that time, I proposed to the training division. Then they came in. Many of them qualified and hold very good posts in local, also in the international arena, di luar negara dan dalam negara. Yeah. Okay. Next. So the presentation, that was a whole presentation, but since 2020, our presentation is more for the webinar and virtual presentation, not much of face-to-face. But this year slowly, we have the presentation by physical. We hope next year kalau ada di Husada, kita boleh pergi physical ya, ke sana ya, ke Medan ya. Dekat saja Medan.
Ya, Prof.
Medan
Come
dengan dia.
join with.
Ya, Medan and itu tak jauh lah, berapa jam saja, 2 jam saja ya. Okay, insyaAllah. So this was the last in year 2014. I went there to Jeddah for the conference. Yeah, okay. And my last trip to Saudi in year 2019. So that was 3 years ago. Dekat High City for the presentation. Next one. We also involve as the role of the healthcare provider. We also must show as a role model, whereby to take part in the activities, because this is in line with our role as a healthcare provider, especially for the community project. Yeah. So in the SDG 17 goals, we have to understand that we take part in this SDG, ada community, and ada what to say, city, yeah. And I would like to promote you all, those participants, those students. I am sure you have your own association. Please, when you qualify, join your Indonesian association, professional association, because during that time, when you are in the group, you can have networking, you collaborate, and you have many other healthcare provider around the globe, and we can mix together and we can have networking and collaborate each other. A lot of ideas will come out. So that is how, as the saying goes, you want to go fast, you go alone, but we want to go far, we go together. Yeah, so that is all about networking and collaboration. Yeah. Okay. Next. Oh, this is one of the convocation. Husada, is it apa convocation apa dalam bahasa Indonesia, ya? Husada, is it? Husada.
Husada, Prof.
Husada, ya, Husada.
Husada, Prof.
Yes.
Mitra Husada.
Mitra Husada. So
Yes,
saya
Prof.
ingat lagi. So apart from this networking, we also bring our team delegate to have the benchmark visit. So the benchmark visit also as to see what are the best practice there. So we come back, we can adopt and adapt. That is what I am talking about benchmark visit. So kita kena ada penanda aras, ya. So from there, we can have like the Indonesian institution datang, kita pun datang ke sana dan sebagainya. So that is about benchmark visit. Yeah. Next one. Oh, this is the delegates that we went to John Hopkins to study what are the best practice there. So because we want to improve, because in the quality, as the saying goes, the largest room in this room is a room for improvement. So there are 12 of us from the private sector, from the government, from the nursing council. We were together to attend this educational visit. Yeah.
Excuse, Prof. We cannot hear because unmute, please, Prof. Okay.
Can hear?
Have here, Prof. Thank
Okay,
you.
okay, sorry. So this is the delegate that 12 of us went to John Hopkins to study what are the best practice, because as the healthcare provider, healthcare workers, we want to learn from the established or the best practice institution. So when we come back, we can adopt and adapt. Yeah, so this is what I am sharing. Yeah, okay. Thank you. Next one. Kita ada every year sambutan Hari Jurawat, Hari Midwife pada 5 Mei, Hari Jurawat 12 Mei. So I hope all the nurses and midwife can take part, and we must show that we are together. That is our role as a healthcare workers. Yeah. Okay. Next. So in the forum, we also have our organizing committee to come up with the theme according to the year. Like last 3 years, the theme is a voice to lead. So this year for the Husada Sekolah Tinggi Kesihatan memilih regarding
Husada.
Husada ya.
Ya, Mitra Husada, Prof.
Mitra Husada Medan memilih on the tema theme ke arah sustainable development goal. Yeah. Okay. So this is something very current, and we have to be involved directly. We must know what are the goals and which one under our role as the healthcare provider. Okay, next one. Okay, these are the visit that I am sharing. Apart from US, we went to UK, we went to Australia. So from this, we learn from each other. Okay, we learn from each other. We want to be the best. We must have a benchmark visit. Then we can have brainstorming. We have a discussion and change idea and so forth. So this was taken place around 5 to 10 years ago, and now they still continue with the benchmarking visit, and I hope our partner, our industrial partner will continue. This is the good practice. Yeah, next one. So I am sharing also as a First Nation nurse been awarded the fellowship to participate in the global nursing leadership in year 2010 at Geneva. So I also like to promote this to our nurses there, or the midwife or the leaders there at Mitra Husada to apply to attend this GNLI for to attend this to get fellowship, and there's a lot of topic to be covered in the leadership and also contemporary issue. So that was 10 years, 12 years ago, whereas we meet all over the world, the global nurses and also midwife throughout the meeting at Geneva. Okay, that is what all about GNLI. Yeah, next one. Okay, this is just continuation, and I am very happy to meet also some of them study in John Hopkins during that time. Few Indonesian students, they were there. Some of them doing their master, they're doing their PhD. So I met them, and they were very happy because some is sponsored by their institution. Okay, these were at the John Hopkins University. Yeah. Next. Okay. What I would like to encourage everyone. Today I can see 451 participants attending this conference, and this is in a conference in Indonesia. So later, all the participants can also go to other country and see how other country conduct their conference, and during that time we can meet face to face. You can have a discussion. Even now also you still can meet only virtual. So seeing is believing. People say seeing is believing. So this is the the meeting had taken place at Melbourne, taken place at Taiwan, and also in Malaysia. So what I said, that is all about knowledge, because knowledge is power. You have to gain knowledge, and learning is a treasure that will follow its owner every day. Yeah. Okay. Next one. So the last conference, the international conference that I attended in year 2017 at Barcelona, Spain. Yeah, okay. And next year, inshallah, at Montreal, Canada. We already registered. Being international relation, I have the opportunity to be given by the university to attend this kind of international conference to have more exposure, and we also can learn from each other. So next year, the conference will take place in Canada, Montreal, Canada, yeah, International Council, yeah. And this is the last photo for the international conference. Next one. I am happy to promote advanced diploma in midwifery. In Mitra Husada, you have midwifery kan? Ada midwifery, betul? Midwifery, kebidanan, ada kebidanan
Have
kan?
midwifery and nursing.
Yes. Tetapi saya tengok some of them ada bachelor in midwifery, betul? Bachelor in midwifery.
Yes, Prof.
Yes. Ada master in midwifery?
Waiting
Ada.
list, Prof.
Okay. So maybe next one go for PhD in midwifery. But in Malaysia, like there at Mitra Husada, your midwifery can go direct, betul tak? Direct entry, betul? Direct entry. But here, they have to be a nurse first, then go for their midwifery. So that means something different. So this is the only private university we conduct the midwifery in the country. The only one, the private university. So we have quite a number of international students with us. Yeah. And that if you can recognize, this is our Tun Dr. Siti Hasma. During that time, we invited her to launch this advanced diploma in midwifery. Former the Tun Dr. Mahathir's wife. Yeah. Okay. Next one. So this is the student midwife. I would like to show because this photo dalam partisipan ni pun ramai juga midwife ya, ada. Okay. Tapi setengah sudah ada bachelor, sudah ada master, very good. Next. Okay. So don't forget, as a healthcare provider, healthcare workers, you have to do a lot of reading to upgrade yourself. And I take this opportunity to also encourage you to do publication, to write that the few book that I've written, and we can share also electronic book with you all there, so that we can have exchange ideas. You can read this book, we can have your publication and so forth. So the more publication, the better for the Setara and the international point, yeah, for the ranking. Yeah, very good. Next one. So this is the award given. Alhamdulillah, in year 2015, I was given as the championess in education award, pendidikan. And I think that's all for the introduction. Thank you for the introduction. I have another slide, please, for my I end with the 3 P here. I am patient, persistent, and perseverance. So this is my motto lah, yeah. Patient, persistent, and perseverance. Inshallah. So we go to the next topic, which is related to today's international conference. Yeah. Ada slide yang saya dah hantar tu? Boleh kita share ya? Okay. Next, this is the last slide kan? The last slide ya? Okay. So this is the journey whereby the alumni of our brand. So this is the apalah yang saya mention tadi, letak di sana. So the most important is you have to if you are not willing to learn, no one can help you. If you are determined to learn, no one can stop you. So that is about you yourself. So mesti ada rasa nak teruskan nak belajar. Teruskan nak belajar. This is very important. Next one. Okay, this those who ever come here, you have met me, and I'm happy to go there, insyaAllah, di Medan, dekat, insyaAllah kita pergi ke Medan pula. Next one. Okay. Okay. Dan kita ada bulletin, kita ada archive dan sebagainya. So this is the photo yang saya share dengan anda. The student, we give you the book for the textbook as a reference. Okay. Inilah pengenalan tentang diri saya in my professional journey. Since coming to 50 years in nursing, with 30 years in education and 20 years in service. Next. Okay, the few talk been carry out semasa pandemik. Kerana itu kita masih lagi dalam SOP. We put on the SOP, tengokkan pakai apa jarak-jarak, penjarakan dan sebagainya. Okay, so that is to show my role as a healthcare professional still, walaupun dalam keadaan pandemic, sebab as a person, healthcare provider, you also carer, you also teacher, you also counselor, your role as a moderator, you facilitator, so you mainkan banyak peranan. So this is part of my role as a healthcare provider, healthcare professional. Next one. Next. Okay, so this is the convocation taken place. Dan kita dah habis tentang convocation. This the student, dia banyak sekarang dah jadi alumni, dah pun bekerja. That is about our student. Okay, next one. Okay, thank you. That is about me. So now we go to the proper topic given to me on the roles of the healthcare workers in supporting the people of all ages. Can you show me the next slide? Can you share the next slide? No, the next slide. Do you have the next slide? Dapat buka tak?
Excuse me, Prof.
Only
that.
Oh, you don't have this is about me. I have the second slide on the topic. You don't have?
Don't have, Prof. Sorry.
Oh, I see. Okay. Do you allow me to share the screen, because I sent through the email this morning. Okay. If you can open, if you can't open, then I have to share from my screen.
Yes.
Can you? Are you able to check your email? Yes.
Excuse, Prof. We will check our email, please.
I already sent this morning for the topic given to me. That is the topic for today. The slide that I sent is about myself as the healthcare professional and my role, what I have to do. Okay. So now is my topic as given by the scientific committee. I'm going to deliver this topic. Are you able to open? If not, I have to share from my screen.
Excuse, Prof. Give time a minute, please.
Okay, it's okay. So never mind. I will read. I will, while waiting for the screen, I will just share with you. This topic given is on the role of the healthcare professional, healthcare workers. With this, what we are to discuss is apa peranan kita. What is the role? Okay. The role of the the healthcare professional, the role of the healthcare healthcare workers. So this is what you have given me. I am sharing the role of healthcare workers to improve health, to improve health status and support well-being for all ages. Yeah. Okay. So this is what I am going to talk about. And my overview presentation, I have introduced myself. Of course, I need to introduce myself to you because I'm from Masa. Masa is the private university, situated at Sarjana Putra, and only half an hour from airport. So very near, half an hour from airport. Then this Masa College is well known as the healthcare institution, health science institution, and we are private university in Malaysia. Yeah. So now is the private university here. We have also at the Jalan University. We have in Sabah, Sarawak. We have here. We have few branches also. Yeah. So this is the private medical university, and founded in year 2004, and with the birth of Masa, we started with the nursing. Yeah. Okay. The health course. Yeah.
Excuse me,
Cannot.
Prof. We have checked by email, but we can access the account, please, Prof.
Okay, so in that case, I can. You allow me to share? Do you allow me to share the screen? How? I can share the screen, right? Wait.
Yeah, Prof.
How to go?
Beside that, we have multiple cells.
Yeah.
Or we
How
can
to?
say,
You mean you can open? You can open?
yes, have opened it, Prof.
Cannot open?
Can
Okay.
open. Cannot.
Oh, cannot open. Yeah, okay. So how to exit minimize?
Or
No, okay,
maybe
go.
please share screen from there, Prof.
Yeah,
please.
okay. I share screen. Yeah.
Yes, Prof.
How to go share screen? Screen. Oh, share screen.
Okay, we can see, Prof.
Can see, yeah?
Yes,
Okay.
Prof.
I can share the screen. Where to go? I can go to this desktop. Webinar. No. Webinar is where to excuse me, yeah. Can see?
Can see, Prof. Still open it.
Yeah, okay. Okay. Is it okay now?
It's okay, Prof.
Okay.
Yes, we can see, Prof.
Okay.
Thank you.
Okay, thank you. So this is the topic given, the role of healthcare workers to improve health status and support well-being for all ages. Yeah. So thank you again for the presentation, and those who already here, they have seen the Masa University with 70 acres, and we have our university in antarabangsa, iaitu sekolah antarabangsa. We are going to have our hospital next year, inshallah, in year 2023. In front of that building, we have that sekolah antarabangsa, and also we have hospital, Masa Specialist Hospital soon. Yeah. Okay. Please let me know if you can't hear. Yeah. So when we talk about the SDG, so we must remember that we also talk about the goals, SDG goals. Okay. So this is something that we prepare our graduate for the SDG goals. So this is one of the program I purposely take for the midwife, because for the midwife, you have the maternal and child and so forth. So I take that one. So now in relation to the in relation to the theme today, by the scientific committee, all health issues in the SDG are integrated into one goal, namely is goal number 3. So when I read the synopsis mukadimah on the webinar ini, you are more focused on the sustainable development goal, which is everyone know about this very well, and we have to support, and we are very very concerned whether this goal can be achieved or not. Yeah. Adakah goal ini akan achieve or not? Because goal number 3 is ensure healthy life and promote well-being for all ages. Sorry, ada spelling mistake itu. So there are 38 sustainable development goal target in the healthcare, and one of the one is very important: reduce maternal mortality and infant mortality. Then controlling HIV, AIDS, TB, dengue, and deaths also due to non-communicable disease, narcotic and alcohol abuse, death and injury due to traffic accidents, and also universal health coverage, contamination and pollution of water, air and soil, and handling of crisis and emergency. When we read the SDG, meaning that in this SDG agenda for 2030, which adopted by all these United Nations member states in year 2015. They have shared this blueprint to peace and prosperity for people and the planet. Yeah, and this is coming into future. So the development, sustainable development goal, which are an urgent call for action by all countries to develop and a global partnership. So they recognize that ending poverty and other deprivation must go hand in hand with strategy that improve health, education, reduce inequality. So meaning that for this, I read about the SDG in Indonesia, but I'm from Malaysia. I will share what is SDG in Malaysia. So that again is the global call to action to end poverty, protect the earth, environment and climate, and ensure that people everywhere can enjoy peace and prosperity. So this target should be reached by 2030. Tapi kalau you baca dia punya laporan, I don't think we reach. Furthermore, with the post-pandemic, ramai yang go to this poverty with the 17 goals. First, the 17 goals said that SDG were expanded in 17 goals, and this target to reach by 2030. And if you read the report, it did not meet yet. Did not meet, especially selepas pandemic ini. No poverty. By the year 2030, no poverty. Then if you read the report, then still, we have another 8 years to go, still. Then zero hunger, tiada kelaparan, sifar kelaparan. And what else? Good health and well-being. This is what we want to discuss. Good health and well-being. And number 3, SDG, number 3, the goal number 3 is quality education. We want to discuss this one, quality education. Then the kesihatan baik dan kesejahteraan, number 3. Pendidikan yang berkualiti, followed by gender inequality and clean water and sanitation, affordable and clean energy, decent work and economic growth, industry and innovation and infrastructure, reduce inequalities and sustainable cities and communities, and responsible consumption and production, climate exchange, and also life below water. That means di mana di bawah air, dia kata kesesamaan, dan juga life on land. Okay, life on land ni macam apa? Kehidupan di darat, ya. Okay, peace, justice and strong institution, keamanan, keadilan dan pertumbuhan, ya. Okay. Then kerjasama demi matlamat. Then partnership for the goal. So I take this for the SDG, the target goal 3, 4, and 17. 17 we have the partnership and for the goals, meaning we must have collaboration. Okay, so now sustainable development goal 3, SDG 3 aim to prevent needless suffering from preventable disease. So premature death by focusing on key target that boost the health of country overall population. So as a healthcare providers, healthcare workers, all these we have to play our role. Reduce maternal mortality. We have the midwife here. Reduce preventable death of children under 5. So what you have to do? What are your role? So end of epidemic. Reduce by 1/3 non-communication, prevention and treatment of substance abuse. So universal access to sexual and reproductive healthcare services. Yeah. So this is universal access and also achieve universal coverage. And from there, the quality education, SDG 4, the key part here, we must know that you have to able to access education, development and training. Yeah. So why is very important? Because we want to ensure our quality education in the relevant manner, positive outcome. Yeah. So we have also the primary, secondary, but in the healthcare education, there are many discipline. Apart from nursing, you have midwife, you have of course doctors, pharmacy, you have inspector kesihatan, public health inspector, you have nutritionist, what else, physiotherapists. So these are the quality education must be provided, and the social, emotional, mental and cognitive development. In this projection of the target group, we hope we can achieve the quality education by year 2030 if you follow this SDG. However, to follow the report, you must check the report yang memang ada dalam website dia, the report dan memang dah ada tu, progress report, ya. Okay, so I go for the quality education because since my background is more on the education, I would like to focus also talk about quality education. Your role as a health professional worker, we are preparing our healthcare professional worker with the good practice and also good education. So that's why the process of skill learn through repeated performance, specialized art of caring, habitual and customary way of caring. So this is all about quality education. So in the nursing program, I am sure in midwifery also, you have 3 years and you have 4 years program. But to ensure the quality of education, as educators, every time when you review the curriculum, you must understand the quality improvement must be there, and what are the renewal of the syllabus, and what are the area to improve. Everything must be there. Remember, health is human right. You have to enhance to make it greater, to increase in value, to improve, to raise up, and to augment. Yeah. Excuse me. So quality of life, how do you measure quality of life? So this all in the syllabus, because we are preparing the healthcare worker towards in improving the health. Yeah. What is the quality life index and based on what? All this should be counted. Excuse me sekejap.
Please unmute, Prof.
Boleh dengar ya? Sekarang boleh dengar?
Sudah, Prof.
Okay. Maaf ya. Hari ini ada sesak sedikit. So the most important as a healthcare provider, mesti ada dalam diri kita untuk selalu improve. We want to have the continuous improvement. That's why in the survey, and we must have the kind of research so that kita ada mindset untuk go for research to improve survey. So what we did every year sebelum student keluar, exploring the student nurses decision making in internship program in the context of university. So from there, we get the feedback, we will improve from the feedback. So this is what I'm sharing. We have to have the evaluation. From there, only we can make the improvement. Yeah. No. Okay. So this is the slide that I'm sharing. It is anticipated that Generation Y will be more than 50% of the nursing workforce, the healthcare workers. Yeah? So the most important, your role as a carer, your role as a facilitator, the role of your healthcare provider, the role as a carer, role as a provider, role as a counselor, educator, a moderator. The important here is culture of safety. Mesti kita fikir bahawa patient is not only the client, but they all are our customer. Not only customer, tapi they are like our client. So we have to take care of the culture of safety. So that is culture of safety is a journey that not a destination. It require continuing diligence. So apa yang kita buat pun mesti ada dalam diri kita culture of safety for our patient. Yeah. So we continue lagi. That is your role. Continue to do something to improve. What you do today, I write this good. What you do today should be better than yesterday. What you're going to do tomorrow should be better than today. So hari ini lebih baik dari hari semalam, hari besok lebih baik dari hari ini. So continuous, ya, continuous. So what they do yesterday itu history. Apa yang akan buat esoknya mystery. But the most important is today, is something reality. What we want to do. So this to explore what they can do the best for our client. So that is the role of our healthcare provider. So excelling in the healthcare, role of the healthcare workers to improve and support well-being of all ages. Yeah. How to be the best? Mesti ada jawapannya. What are you going to do if you want to be the best person? The best healthcare worker. Apa yang you kena buat? Apa indikator yang menunjukkan you are the best? What do you mean by best practice for excelling at customer service? Then how to keep on excelling? How to be superior in some respect or area? What do you mean by quality assurance? This is all the indicator that to show your role as the healthcare worker in your role there to support, to improve the well-being of all ages. And health science, nursing science, behavioral science, semuanya ada belajar. But the most important in you, everyone, you mesti ada critical thinking. I'm referring to many students here. You are we develop you, we prepare you for critical thinking. So critical thinking is intellectually disciplined process of actively and skillfully conceptualizing, applying, analyzing, synthesizing, and evaluating information gathered from generated by observation, experience. So skills, critical thinking, yeah. So that is all about critical thinking. Ini midwife punya program. I would like to share. Anyone can see. I give you the time and maybe give some soalan. You can answer in the chat box. Apa yang you fahamkan dengan enhancing learning by self-made teaching. Nanti kita boleh beri hadiah lah pada siapa yang menang ni, siapa yang betul jawabnya. Apa tu? Dia buat dengan apa tu? Ya, boleh dah saya want to check who can answer this quality improvement project ini. Agaknya this flexible door ni dia buat dengan apa ya? Mechanism of labor ni dengan apa ya? Placenternya dengan apa ya? Because you talk about innovation. Ya, placenta with membrane ni dengan apa you boleh buat? Effacement of the cervix, how they do? Dilatation of cervix, okay. So that is how bulging of membrane. Maybe I leave it to the participant to answer in the chat. Maybe you have some more idea to come up with a good innovation and creativity, yeah. So again, to enhance your role as a midwife, as a nurse also, first you must know your job description. You follow the policy and procedure. You must identify your client. So that is your role. Report all incident and incident involving all your role. The most important, you must have this research-based minded. Your mind. Why we do this? What happened if you did not know? What is the evidence-based practice?
Excuse
what
me.
is, yeah, okay.
There's only 5 minutes
Oh,
left.
5 minutes.
And
Yeah, okay.
a question and answer session will be continued after 5 minutes.
Okay. So I think I can go briefly. This is the future of the nurses, and we also go around the globe, not only in Malaysia. I went to Saudi, I went to Pakistan to deliver the topic and to continue for the continuous professional development. Yeah. So the most important, you remember that every day you must think that something what you want to do. Now the new technology with the di Japan, aging society facing a predicted shortfall. So what are the technology? Dia ganti dengan robot, yeah. Okay, so I understand that many of the Indonesian healthcare provider go to Japan. So that is what I understand, yeah. Okay. That is about the ethics, work ethics. The most important, the work ethics. This is what I am sharing. Di mana-mana kita pergi, kita cari tempat yang kita boleh buat lawatan dan belajar untuk mendapatkan the best practice. So when I went to this place, Malta, I went to visit the elderly care center. We see what are the best practice. We come back, we try to adopt and adapt. Yeah. So this is about learning again. It's a treasure that will follow its owner everywhere. So please, one of the role, you as a healthcare provider, you must be good in your negotiation skills. So this is what I want to share with you. Also, when you come back from your clinical practice and so forth, you must share, you must talk what are the area to improve. Then only you can develop the critical thinking. So your role is not only stagnant. You are going to expand and expand your role in improving the healthcare and improving the wellness and also well-being of our people, of the people. So the challenges, inilah challenges yang kita akan hadapi. Changing pattern in disease, demographic changes, new technology, increasing consumer knowledge, increasing demand for quality care. Yeah, okay. So I hope everyone will continue your lifelong learning as a healthcare worker. Terus belajar, learn, unlearn, yeah, because what you learn today maybe dah tak lagi current. What you learned 10 years ago is now changed, yeah. So core competence is very important. You must have a good communication skills. You must have your language skill, technical skills, analytical skills, IT skill, writing skill, and knowledge in social. Okay. So my advice, the take-home message, you don't look for the next opportunity because the one you have in hand is the opportunity. Jangan tunggu, oh nantilah saya baru nak pergi belajar. No, if you have the opportunity, you teruskan. So your professional responsibility of continuous learning appropriate to their individuals need to achieve professional and personal growth. So this is all about people in this world. I hope you be the number one, those who make things happen. Don't be those who think they make happen. Itu lembu punya susu, sapi dapat nama. Kita tak mau itu. People claim other people got credit from other people. Don't be like those who watch things happen. Don't be like those who wonder what happened. Those that did not know that anything had happened. With that, I thank you. Terima kasih. Dan saya mohon maaf di atas segala kekurangan. Dan yang baik itu dari Allah Subhanahu Wa Taala. Yang kurang itu dari saya. Sekian. Wabillahi taufiq. Wassalamualaikum warahmatullahi wabarakatuh.
Okay, thank you so much. Amazing experience, Prof. Zahra, so that make us more motivation to move forward because we have education visit from USA, Washington, Geneva, Barcelona, and China, and etc. Like that, Prof. Yeah.
Yeah,
Okay,
inshallah,
Prof.
inshallah.
Here have 5 questions, but sorry, only limited 2 questions. So that we take one from Zoom and one from the audience. From Zoom, from Putri. The question, how to provide excellent service as healthcare professional. And the second question, Prof, from Vivi Kartika, have here. Time is yours, Vivi. This is the question from Vivi Kartika, please.
Thank you for the time you given to me, ma'am. Here I want to ask about what is the maternal mortality rate and baby mortality rate in Malaysia? And has the target been achieved of SDGs? And what the effort implemented in Malaysia to achieve the target of the maternal mortality rate and baby mortality rate? Thank you, ma'am.
Thank you, Vivi. Okay, Prof, to question only because considering our time, to Prof. Zahra, time's yours.
Okay, thank you. Okay. Question number one. How to be excellent, is it?
Excellent service, right, Prof?
Excellent service. So number one, everything
Yes, Prof.
is in you. Yeah, everything is in you. You have to have a good habit. To me, you must have a good habit because like what we used to hear, that 10 habits of successful person. You must have your time management, good time management. You must have you must be knowledgeable, must have semangat untuk terus menimba ilmu, kan? Ilmu itu boleh bertambah dan ilmu itu boleh berkurang. Mesti selalu menimba ilmu. Bila ada semangat nak menimba ilmu, barulah kita boleh katakan kita what to say, kita ada knowledge. Because the most important to me, I would like to share with you. ASK, that means attitude. Your attitude must be positive, selalu positif, dan you ada semangat ingin ingin mengubah kepada yang terbaik. That means your attitude. Dan bagaimana menjadi terbaik. Sebab ASK ini penting. Your attitude is very important. No point, some people got very good knowledge tetapi attitude dia tak bagus. Itu tak boleh, ya. Then number 2 is your S, skill. You must be good, competent in your skills. Kalau you bidan, you mesti pandai conduct delivery, normal delivery, you conduct, you buat patient pandai, you check the semua very good skills. I mean your skill. How you advise your bagi education kepada mother, macam mana. That is pertaining to your job scope and your skill. Then of course, number 3 tu knowledge, ASK. Knowledge is power. You have knowledge. People used to say you have a property, you kena jaga property. You have property, you have to take care of property. But you have knowledge, knowledge will take care of you. Jika anda ada harta benda, you kena jaga dia. Tapi you ada knowledge, you boleh bawa knowledge tu ke mana-mana, ya. So, adakah saya menjawab soalan itu?
Okay, to Putri question has been answered, yeah. Prof say knowledge and attitude must be balanced like that, yeah, Prof.
Yeah,
We
okay, must
hope
be balanced.
they
ASK, ya, ASK.
Yes, Prof. Can provide an answer to her question. The question number 2, please, Prof.
The question, is it on the current infant mortality rate? Kalau di Malaysia lah, saya boleh bagi di Malaysia lah, ya. Okay, kalau di Malaysia, actually now is decline lah. Dulu dia kata for Malaysia in 2020 is 5.301 kalau saya tengok dalam report ini. Death per 1,000 live birth. So 2.75 decline from 2021. So the infant mortality rate for Malaysia in 2021 was 5.4 death per 1,000 live birth. So decline from 2020. I'm not sure yang Indonesia berapa, tapi that is the rate for Malaysia lah. So the current Malaysia coverage of the mortality bermaksud kita ada decline lah, ya. And what was the infant mortality rate in 19 itu yang lama, tapi yang sekarang ni seperti soalan ditanya, saya refer kepada report yang memang adalah, kita boleh check kan dalam report ada dalam data statistik under Malaysian infant mortality rate yang dikeluarkan oleh Macro Trends in year 1950 up to 2022. The current infant mortality rate is 5.301 death per 1,000 live births. So dia decline lah daripada 2021. Adakah saya menjawab soalan?
Excuse Fifi.
Okay, ma'am. Thank you for your answer. Thank you, ma'am.
Okay, thank you, Prof. From Fifi is thank you so much. Say thank you so much. The answer by the question, Fifi. Prof, we are very grateful for today excellent material, Prof. Thank you so much, Prof. So that, Madam, we hope Prof. Jara have time to meet up and explain your knowledge again to Stikes Mitra Husada Medan, Prof. And then
Ramainya ramainya peserta ya, 400 lebih, baguslah. Very
yes,
good.
Prof.
Very good response, very good. Congratulations.
1 minute ago have 500, Prof. This is
Masya Allah.
400. Maybe
Oh,
by
Masya Allah.
Wi-Fi or maybe internet like that, Prof.
Yeah, interrupt. Yes, maybe internet interruption.
Yes,
So,
Prof.
yes. Please give question. Sama ada question saya boleh jawab. Kalau ada masa, I am here to listen to your question. Kalau saya boleh jawab, saya cuba jawab. Kalau tidak boleh, boleh email kepada saya. Then I am, saya boleh letak situ email address lah. Siapa untuk nak email pun boleh ya. Okay.
Okay, thank you, Prof. To our audience, this is Prof. Zahra give by email. So we have the question is not give the answer in this event. We can ask the Prof. Zahra like that, ya, Prof, ya.
Ya, insyaAllah, boleh.
Once again, Prof, we are very grateful today for your material about the nursing and midwifery. It's very excellent. And hope and next time we can meet up again in Indonesia or Malaysia Masya University.
Ya, kita mau pergi di sana lah pula ya. Boleh kita pergi ke sana.
Happy to meet, Prof. We will stay waiting, Prof. And then we give time to our moderate to give certificate.
Okay, thank you very much from the moderator to lead our discussion for today with Prof. Zahra. Now, giving the certificate as a keynote speaker to Prof. Zahra Saad in virtual Zoom meeting, a symbolical and given by the Chief of Stikes Mitra Husada Medan, Madam Dr. Siti Nurwan Sinaga SKM MKes. Give him applause.
Thank you. Terima kasih.
Terima kasih kembali, Prof.
Okay, thank you. The time, the moderate, it's yours. Excuse Prof. This time to the session 3 and Prof. Zahra to main room. Thank you, Prof. And thank you for the audience.
And now giving the certificate for from the Chief of Stikas Mitra Husada Medan to the moderator. Okay, thank you for Madam Esther Simanullang, who has been the moderator for the second keynote speaker. And now we enter to the third keynote speaker. But before that, we waiting he join with us. We will see again the traditional dance from the UNIF student of Stikas Mitra Husada Medan. Please enjoy.
Well, thank you for the traditional dancing or creative dancing from Univ students of Stikas Mitra Husada Medan. Well, before we next to the next keynote speakers, I want to tell to the all participants to fill out the satisfaction and attendance link in Zoom. We have sent in chat room of Zoom meeting. Once again, I want to tell you that all of us as a participant today fill out the satisfaction and attendance links already sent in Zoom meeting. Thank you.
Well, ladies and gentlemen, we are entered to the third keynote speakers. But before that, I will introduce the moderator in this time is Mr. Edi Marjuang Purba, Master of Public Health, he is a lecturer in Stikas Mitra Husada Medan, and he was graduate master from University Gajah Mada, Yogyakarta. Please welcome Mr. Edi Marjuang. But we still waiting, the third keynote speaker, because we have different time. Maybe in there still in the morning, and now here in the day. So we will waiting for a second minute. Thank you.
Okay, because we are waiting the third speaker in the schedule. The time is 12 here, 12 p.m. So we have 5 minutes left. Okay, Dr. Sid, have you here? Not yet. Okay, we are waiting him because she is in London and now they're still morning. Yeah, still morning. So maybe already wake up maybe. Dr. Sid, have you here? Not yet. Yeah, maybe we have time to relax. Maybe have you enthusiastic the participant all of here and in the Zoom? Still you in enthusiastic or spirit? Okay, we are waiting. Dr. Sid Sidaruda Sivali, have you here? Hello, Dr. Sid, are you here?
Hello, good morning.
Yeah, good morning from Indonesia. Are you in London now? Yeah.
Yeah.
Okay. Because we are going to the third plenary session, and now is your time. So before we are going to your topic, I will read your CV. Yeah, Dr. Sidaruda Sivali, MBBS, MD. He graduated in medicine from India and complete post-graduation in community medicine from Banaras Hindu University, India in 2017. He completed PhD Leader Fellowship, jointly awarded by Rollins School of Public Health, Emory University, USA, Public Health, Foundation of India, New Delhi, India, and Institut Nacional de Salud Publicates, Mexico. Before joining LSHTM, he worked as non-communicable disease regional technical advisor Southeast Asia. And now he worked in London School of Hygiene and Tropical Medicine. He research focus for non-communicable disease prevention and also maternal and child health, and then nutritional. Until here, so many publication in international journal in Q1 and Q2 also. And now the title will be shared. The title is Role of Healthcare Worker in Public and Indian Perspective. For Dr. Sid, you have time around 1 hour, 45 minutes for talk in and 15 minutes for discuss. And for participant, if you have any question, please write in chat room. I will read your question. Okay, now Dr. Sid, time is yours.
Thank you. Thank you so much for kind introduction. I hope you can hear me.
Yeah, we can.
I'll share my screen now. Can you see the screen?
Yeah, we can see.
Okay, great. I'll just make it full screen. Okay, is it visible?
Yeah.
Okay, great. Thank you. Thanks. First of all, at the outset, I'd like to thank the organizers, particularly Eddie, for giving me this opportunity to talk on what has been my experience with the healthcare workers in public health from Indian perspective. So thanks a lot. And it's an honor to share my experience on an international conference. And yeah. So I'll be talking about the role of healthcare workers in public health and Indian perspective. And my name is Dr. Shivalli. I currently work at the London School of Hygiene and Tropical Medicine, London, as an assistant professor in epidemiology. So these are the points which I would like to cover in today's talk. An overview of Indian public health system. I mean, I know there is a lot of similarities with the Indonesian and the Indian public health system because I worked as consultant to Definite, and there are a lot of similarities. But before we jump into the main topic, I thought we should have an overview so that those who are not so aware of Indian system are well aware. We do have a three-tier system, which I'll talk more about in the subsequent slides. And who are the various cadres of healthcare workers in India? I mean, obviously, according to CDC definition, it includes all the entire spectrum, right from the doctor to the nurses to the lab technicians and to the community healthcare workers. What I'll be focusing who work at the grassroots level, that is the nurses and the community healthcare workers. So those are the on the forefront of the public health system in India to deliver the essential services, and they play a key role. Obviously, doctor plays a key role, but majority of the population is served by these three or two cadres of workers. And we'll talk a bit about task shifting, why it is important, because this is very much an essential concept in developing countries like India and Indonesia. So why this task shifting? What do you mean by that? Why it is important and how it is done? Then what's the role of healthcare workers in public health in India? So we'll talk a brief on that. What kind of responsibilities they take? Mainly the focus is on maternal and child health, but now their job description is expanded to other non-communicable diseases, and obviously the communicable disease which have a particular program. For instance, for TB, we have a national TB elimination program. For vector-borne diseases, we have a program. So similar to Indonesia, which adopting the WHO guidelines. So they do have responsibilities in all those programs, but mainly focusing on maternal and child health. Then we'll talk about what are the challenges, what I have observed for community health workers in India, and what are the possible ways forward, how we can deal with it. So I think these points make sense. And if you have any questions, I don't know how it's working. Maybe you can put it in the chat, or we can discuss those at the end. So to begin with, an overview of Indian public health system. Earlier we had individual programs. We call them as vertical program, like one for TB, one for vector-borne diseases like malaria, and one for non-communicable disease. But all these were clubbed and put under one umbrella. That's called National Health Mission. It's a mission which emphasizes achievement of universal access to equitable, affordable, and quality healthcare services that are accountable and responsive to people's needs. So they all merged and placed under one umbrella. So yeah, so that it becomes very easy from managerial point of view. And in that we have two broad submissions. One mainly focusing on the rural areas of India, because nearly 60% of the Indian population lives in rural areas, and we need to have
Excuse
different
me, Dr.
strategies
Sid.
to address
Can
the
you-
healthcare need of those people.
Dr. Sid,
Yes.
can you talk more loud?
Oh, sorry. Okay.
Thank you.
Am I audible now?
Yes.
Okay. Is it better? Okay. Okay, so the National Health Mission is a broad umbrella where all the programs are put together. So it has two submissions. One is focusing on the rural population that constitutes about 60% of the Indian population, and the national we call it as National Rural Health Mission, and the urban counterpart, which mainly focuses on the vulnerable populations, particularly who are below poverty line or living in the slums. So that is known as National Urban Health Mission. So the National Rural Health Mission began way back in 2005, and the urban counterpart, that is NUHM, was introduced in 2013. So we'll talk a bit more on those things in the subsequent slides. So the common thing for both urban and rural part is these programmatic components, that is health system strengthening, mainly focusing on reproductive, maternal, neonatal, child and adolescent health, that we call it as RMNCH plus A. It gives a kind of life cycle approach for the maternal and child health issues. And obviously we had communicable disease, but now we have also included non-communicable disease, mainly diabetes, hypertension, and cancer-related diseases. So, National Rural Health Mission was launched, by the Prime Minister of India on the 12th of April in 2005, and the main aim was to provide accessible, affordable, and quality health care to the rural population, especially the vulnerable groups, especially establishing a fully functional, community-owned, and decentralized healthcare delivery system with intersectoral convergence at all the level. Yeah, so this is how the broadly the infrastructure of the NRHM works. Like a typical pyramid model. Bottom forms the grassroots level structure, that is at the village level. Then we have a sub center. Then we have primary health center and the block level or secondary level hospitals. So in NRHM or NUHM, the district acts as a functional unit. The whole country has about 29-30 states, and each state have many districts. So those districts act as a functional unit. And in those districts, each district has one district hospital, which is a kind of tertiary level care. And irrespective of the size of the district or population size, and at each village level in rural areas, we have something called community healthcare workers. We call them ASHA, Anganwadi workers. I'll come to them those details in a bit later. So these ASHAs and Anganwadi workers, they conduct something called Village Health and Nutrition Day, where they come together. They convert, because the ASHA is appointed by different ministry and the Anganwadi is appointed from the different ministries. So they come together and they work with a nurse. Nurse is the one who is there in sub center. So every village approximately has around 1,500 to 2,000 population, and for every village we have one ASHA and one Anganwadi worker, and for the sub center is there for every 5 to 6,000 population. That means about 5 to 6 villages are covered by one sub center, and that one sub center is headed by a nurse, or we call her as ANM. So this ANM visits all the villages under her area, and in each village, whenever she goes, she coordinates with the ASHA and Anganwadi. So they work as a community link workers. They mobilize the pregnant women or children for immunization or any other issues on one particular day in a month. So that's how they converse together. So I can share you the nice beautiful diagram later. So this is at the grassroots level. Then we have PHC for about every 30 to 40,000 population, which is headed by one general practitioner. And under that, they have various staffs, including staff nurses, pharmacists, and all those people who are required to provide essential primary care services for 30 to 40,000 population. Of course, this population norm again varies. If it's a very hilly and tribal area, it would it would the population goes down, up to 10,000 also there is a population PHC. Then we have referral services, government managed ambulance services whenever there is a requirement for emergencies, including maternal child health services. And at above this PHC, for every 1 lakh population, we have community health centers. So these are community health centers have specialists like a pediatrician, gynecologist. So where we can provide specialized services. And above that, we have a district hospital, which is like a headquarter of the district, where we have all the specialists and including surgical facilities. So this is how the 3-tier system works in India in the rural part. I see a lot of charts. Eddie, you want me to continue, or we'll take all those questions at the end?
Yeah, I think you continue.
Okay, thank you. Okay, so now come to the urban counterpart, the National Urban Health Mission, which was launched in 2013 because Government of India saw a significant improvement in the rural health indicators, which I'll be sharing later. And to build on the success of the National Rural Health Mission and to address the needs of the urban population, focusing on the urban poor, they launched National Urban Health Mission with the same idea, to have ASHAs and ANMs also in the urban areas. So the main aim was to meet the healthcare needs of the urban population with a special focus on urban poor and ensuring availability of essential primary healthcare services and reducing out-of-pocket expenses for treatment. Obviously, all of you know, in developing countries like India and Indonesia, many of us do not have health insurance. So we often end up with out-of-pocket expenses for any kind of ailment. So yeah, and I because of those out-of-pocket expenses, many people who are not above poverty line are forced to go below poverty line because they have to sell their asset, whatever they have, to get the treatment, because government doesn't provide a comprehensive health policy. And private sector still plays a major role. Nearly 80% of the urban population is treated by the private sector. So yeah, that's the thing. So it began with covering all the state capitals, district headquarters, and any city or town with a population of more than 50,000. So 50,000 was set as a cutoff. Anything above that will have a National Urban Health Mission infrastructure. So it's very much similar to the infrastructure under National Urban Health Mission is very much similar to National Rural Health Mission. Like at the community, at the grassroots, we have, again, it also follows a 3-tier healthcare model. So at the community level or the what we call ward level, we have community outreach service, mainly headed by auxiliary nurse, midwife, and ASHA. We have urban counterpart ASHA. Sometimes we call her USHA. ASHA and USHA are the acronyms. ASHA stands for Accredited Social Health Activist. So that an acronym, we call it, we call it as ASHA, and that's for a National Rural Health Mission. The urban counterpart, we call it as Urban Social Health Activist, that is USHA. So these are the common Indian woman names. So that's how the acronyms are formed, so that it's very easy for the people to remember. And there is one urban health center for every 50,000 population. This is very much same as that of primary health center, which is there in the rural areas. And above that, we have referral services, and it is directly linked to district hospital in the it's a common district hospital is common. It caters to both rural and urban areas. Sometimes we have another layer of secondary level care that we call it as cooperative hospital by the government in some places, which is very much similar to community health center, which is there for every 1 lakh population in rural parts of India. So hope I have made it clear that you got a point. We have how the 3-tier system works in rural and urban areas. So just to give an idea that how the urban healthcare facilities work. So at the if you can see here, for every about 200 to 500 household or about 1,000 to 2,000 population, there is one community health volunteer. We call her Asha. And for every 10,000 population, there is one ANM, that is auxiliary nurse midwife. That means one ANM will be supervising about 4 ASHA. Similarly, we had it in the rural part where about 4 to 5 ASHAs and Anganwadi workers are supervised by ANM. Obviously, this is only health infrastructure. There is also Anganwadi worker in the urban area, and they again converge and work together. And an urban PHC or UPHC for every 50,000 population with this staff. And this is urban CHC, as I said, which has indoor admission facilities with 30 to 50 beds, which is there for every 2.5 lakh population. Now we'll go to the next point. That is, I hope I am able to give an overview of how the Indian public health system works. Now we'll talk about which are the different healthcare cadres of the healthcare workers in India. So, as I said, according to CDC definition, healthcare worker includes all the entire spectrum. Like the allopathic doctors who practice modern medicine in India, and they get either graduates or diploma, postgraduate diploma degree, and everything is managed by National Medical Council. Now, Medical Council of India is replaced by National Medical Council. We have dentists, we have traditional practitioners. We call them as Ayush practitioners, and that is registered and managed by Department of Ayush and Ministry of Health and Family Welfare. We have the nurses. We have auxiliary nurse midwives. Nurses are the graduates, whereas the ANMs are hold a diploma degree. And here we have a council, and here it is managed by Ministry of Health and Family Welfare. We have pharmacists, we have physiotherapists, diagnostics, and all those things. Now, these are the two important community-based healthcare workers, accredited social health activist, we call it ASHA, and Anganwadi worker. Both are trained female community health workers. Remember, ASHA is an activist, meaning she doesn't get a fixed salary. She gets performance-based incentives. She is given certain tasks, and as on when she complete tasks, depending upon number of tasks completed, she'll get the incentive. So there is no fixed salary. That's why she's called as activist. Whereas Anganwadi worker is a worker who gets fixed salary. She is appointed under a scheme called Integrated Child Development Services Scheme, which provides supplementary nutrition to under 5 children and pregnant women and lactating women. She is a worker. She gets a fixed salary from the Ministry of Social Welfare. So those are the things. What I'll be mainly talking about is ANM, ASHA, and Anganwadi. Now let's talk about task shifting, why, what it is, why, and how it is done in most of the developing countries. So I'm sure most of you are aware. Task shifting is from developing countries' perspective. We cannot have doctor or specialist in every parts of the country. We don't have the ideal doctor population ratio. So the best way to deal with this, you transfer or redistribute the tasks from more specialized to less specialized, or from highly qualified to person with fewer qualification, so that you try to address the major public health issues. Okay, so it's according to WHO definition, it's the rational redistribution of tasks among health workforce teams. So specific tasks are moved where appropriate from highly qualified health workers to health workers who have fewer qualification. For instance, from doctors to nurses, and from nurses to community health link workers like ASHA and Anganwadis and equivalent community link workers in Indonesia. So this is the idea of task shifting, which is very much essential. It's a process of delegation whereby tasks are moved from highly specialized workforce to less specialized health workers. It's a great option and method to enhance efficiency on delivery of healthcare. Obviously, because we don't have a specialist everywhere, that's why this works as a very good alternative. The why it is necessary, the answer is very obvious. The world is experiencing a chronic shortage of well-trained workers. I mean, it's true even for developed countries that there is a shortage. There is always a shortage, and that is even more obvious in developing countries like Indonesia and India. So according to WHO, sub-Saharan Africa countries, Bangladesh, India, and Indonesia are facing a severe problem. I see in many parts of the India where there is a center, but there is no ANM or medical personnel to manage the case. So that's the thing. And there is a requirement of more than 4 million health workers, to fill this, human resource gap. And global deficit of doctors, nurses, and midwives is at least about 2.4 million. So this is how task shifting works. It starts with a specialized, I hope you can see my cursor, starts with doctors who specialized physicians. They transfer certain skills or tasks to non-physician clinicians, and 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 these non-physician clinicians again transfer it to second level, that is nurses. Then it goes to nursing assistants or community health workers, and task shifting again to expert patients. Sometimes uh, old patient is better than a new doctor, so sometimes old patients do help in such things. So yeah, this is how the task shifting happens. In Indian perspective, we don't have non-physician clinicians, so doctors train nurses, and nurses in turn train the community health workers, that is Ashas and Anganwadis. So that's about task shifting. I hope I have made it very clear. Now, what is the exact role of these ANM, Asha, and Anganwadi workers in India? So this is how they work together. As I said, mainly focusing on the maternal and child health. And as I said, the ANM has a population under her to be covered. So she prepares a micro plan. So let's say she has 4 villages in her sub-center area, and she plans that every village she'll visit every week, so that at least she will visit each and every village once in a month. So that we call it as micro planning. She'll plan, prepare that plan in consultation with the Anganwadi and Asha in each village. And whenever she visits a particular village in once in a month, we call it as Village Health and Nutrition Day. We try to celebrate it like a local festival. And what's the main purpose? The ANM will come on that day to her to that village, and Asha's supposed to mobilize the adult population, that is pregnant and lactating women, and also now the above 40 population, whoever has any issues, including diabetes and hypertension. Whereas Anganwadi worker is runs a separate pre-formal school for under 5 kids. So the kids are already there. So she is supposed to mobilize them for immunization on that day. So according to the national immunization schedule. And on that day, ANM does all the examinations for pregnant women, giving appropriate advices and all those things, and obviously immunization services. So this is how it works. So the supplementary nutrition is provided by the Anganwadi worker. She has a pre-packed foods, or sometimes prepared, at the Anganwadi center. She has a helper to prepare the food while she is teaching, and it is given to children below 6 years and pregnant and lactating women. Immunization services up to 6 years. Health checkup for all children, pregnant women, that is mainly done by ANM. Mobilization is done by Asha and Anganwadi worker. And whenever there is a need, they refer to higher center like PHC or CHC, depending upon the need. And as I said, informal preschool education is mainly the job of Anganwadi worker, right? And about nutrition and health education, they all three together do that. So rather than this table, if you look at this Venn diagram, you'll get an idea how these three people, that is mainly headed by nurse, ANM, the Asha from Ministry of Health and Family Welfare, the Anganwadi worker from the Ministry of Social Justice. So all these three have their responsibilities, and these are the responsibilities where all three of the people do, that is education services on nutrition and village health nutrition and days, community-based planning, monitoring system, whereas A&M mainly leads in providing the care and suggesting on institutional delivery, postnatal care, and immunization. Asha also has certain facilities, like she carries IFA, iron and folic acid tablets. She has ORS sachets with her. She carries family planning, facilities, including condoms and even pills, oral contraceptive pills. Whereas Anganwadi worker is mainly doing the nutrition supplementation, and she is the one who monitors the growth. She's been given with WHO cards, so accordingly she plots and keeps monitoring. And whenever there is a issue with the growth monitoring, again she will consult the A&M. So this is how they converge and work together. So this was nicely prepared by this Venn diagram by Glandon et al. In his MSc thesis from Johns Hopkins. I hope it's clear. So, so next question is, yes, we have a nice system, but is it working? So are these community healthcare workers in India effective? So as I said, these workers started in rural area from 2005 and in urban from 2013. And since the launch of National Rural Health Mission, India has seen a significant reduction in maternal and neonatal mortality. You can see the figure, it was to the tune of 254 in 2005, and now it is somewhere around 122. So it has been reduced by half. Similarly, with the neonatal mortality, that is from 38 to it has become 23 per thousand live births. And it is mainly due to increased access to essential services, promoting institutional deliveries, because the ASHA gets, as I said, performance-based incentive. So whenever she escorts a pregnant woman for institutional delivery, ASHA gets incentive, and also the pregnant woman also gets the incentive. So that's subsidized demand side financing. So these are the three key things which help to reduce these maternal and neonatal mortalities. But however, we still lag on the sustainable development goal targeted for 2030. There are issues, which need to be addressed. Yes, we have addressed at one level, but to gain further improvements, we need to address on the other aspect. I'll come to that. So you can see these key indicators. There was a recent survey, we call it as National Family and Household Survey, round 5, which was conducted in 2019 to 21. And these are the indicators. You can see neonatal mortality. It has been reduced to 24.9 from 29 way back in 2015 and 16. Same with the infant mortality to 35. Overall under 5 has also been reduced from 49.7 to 41.9. So you can see various indicators. There is an improvement. As I said, ASHA and A&M also provide family planning services. So you can see there is a gradual improvement in adopting the various family planning services. Like any method, we have about 66, and any modern method 56. This is tubectomy, this is vasectomy, and all these IU series. So you can see when you compare to the previous thing, there has been significant improvement. And also there is discrepancy between urban and rural area. This is urban and this is rural. And the unmet need has come down. It was earlier 5.7, now it was 4. Now coming to other maternal child health, you can see, what type of antenatal care is given, like the mother who had antenatal care in the first trimester, or according to WHO, how many had at least 4 ANC, all are on increasing time, from 51 to 58, 58 to 70, and institutional deliveries, those who received neonatal tetanus from 89 to 92, those who consume IFA, this is an issue, I can talk about this later. And out-of-pocket expenditure was also reduced from 3,100 to 2,900. So all these show improvement. And institutional birth, there has been significant improvement across the whole of India, from 78.9 to 88.9. Obviously, this was much lower when NRHM was not launched. So there has been steady increase, and yeah, you can see those. So again, immunization, there is we have already achieved a significant improvement. So there is little or just the progress has been maintained with respect to under 5 child immunization. And now, from 2015 to 16, a new thing was introduced in the survey to detect blood sugar level. So I think these are also being reported, mainly done by ANM at the grassroots. So you can see that, we have the national level data on the prevalence of diabetes and the hypertension. So definitely it's working. In the last World Health Assembly, post-COVID, looking at the fantastic contribution of the ASHAs, WHO awarded the India's accredited health activist, global champion award. ASHA in general, it's not given to one particular ASHA, all the ASHAs in India. So that was one proud thing for India for their outstanding contribution towards protecting and promoting health. And Asha in Hindi means, it's a Hindi word, which means hope. So as I mentioned, she provides all these services. Yes, so quantity wise, it looks very, very good. But, to gain further improvement, now the focus should shift on quality. There was a study done by Indian Council of Medical Research. It was not a, it was actually a secondary data analysis of the same national family and household survey. They looked at quality of antenatal care services. Quality in the sense, they looked at 4 different dimensions, not just the number of antenatal visits, whether visit was by the skilled healthcare or whether it was timely, whether it was timely or not, whether it was in sufficient number or not, and most importantly, appropriateness in the content. That is, they had a set of indicators like each time her blood pressure was measured or not, her weight was measured or not, was she given IFA or not, and whether her hemoglobin was checked or not. So they had set of 8 to 9 indicators, and they had set a minimum criteria, at least 7 should have been met. So if you see here, any skilled ANC is higher, but if you come down, it goes down. The first ANC drastically reduces, and those who had 4 ANC also reduces, but it further reduces when you look at the appropriateness. That means ANM is not providing all those services. Probably out of 8, she's providing 1 or 2 services, and that's the thing. So that's the one surprising thing. So if you look at the state-wise distribution of data, where what proportion of women receive adequate. Adequate means all these 4 criteria are satisfied. So if you see, only 3 states, 1, 2, and 3 states reached to the mark of 60. That means 60% and above of the pregnant women receive adequate antenatal service. So quality is still lacking, and only about additional 3 more, that is 50% or more of the women receive adequate services. So rest of all the states lack with respect to quality of antenatal care. So this is the area where they need to focus on. And we also did a recent study in India on about 800 odd pregnant women. So the same story, if you look at the appropriateness of the antenatal care, like for weighing the, measuring her weight, blood pressure, abdominal examination, tetanus, urine, blood test. So some of the things are very high. For instance, blood pressure and weight measurement and the TT are very high, but some of the things are not so high. So these are the quality issues which need to be addressed, because all these are essential services which are to be done, because pregnancy is very unpredictable, and unless we do all this, we'll not be able to detect all the complications or any complications which require immediate referral. So these are the things we need to focus on. Okay, so what are the challenges? Yes, we know quality is an issue, but why this is an issue? There are a lot of qualitative studies done, including these ANMs. So these are the things which which have come out. One is, there is no pre-service training. Once the ANM is appointed, they do give pre-service training, but it is more of a theoretical. There is lack of hands-on experience. So that's an issue, because if you are posting someone without hands-on experience, obviously she'll not be able to deliver quality services. And there is no regular structured evaluation after training due to lack of resources and lack of effective supervision. We do have a supervisor, we call her as lady health visitor, but it's not effective. And existing supervision focuses on only checking the reports. It's not about how she solves the problem at the ground, or how are her clinical observations. So it's not done. It's just checking on the report. So what ANM does, she just completes all those reports, even though she's not actually doing on the ground. So this is an issue. And these all observations are told by the ANMs only. It's not that we have done. These are all qualitative research-based observations. And another important thing is no accountability. It's very hard to monitor each and every ANM at the each village, right? So there is no accountability, and we do not have a career pathway to progress. ANM can move at the most to the next level, that is lady health visitor. So there is no further scope for her to progress in her career, and that progress is absolutely not there for Anganwadi and Asha. It just stops there. So these are the issues. Probably they feel that there is no progress. And excessive workload. Yeah, I mean, because in many villages some of the ANMs are not there, so the other ANM has to cover. And sometimes it becomes very exhaustive, because she has to carry the papers uh, uh, and carry 3 or 4 registers. One register for immunization, one for nutrition, one for pregnant women, one for others. So she has to carry so many books and keep recording, and again she has to report back with another form. So with more than 2 indicators, which is very exhaustive. The whole focus shifts on maintaining the records rather than providing the service. And she is often penalized for non-performing performance or apply sanctions. So they said that they undergo salary cut. So that's another issue which demotivates them to provide quality service. So and these penalization are based on records, not by, as I said, based on the services of problem solving or clinical decision making. And forced to do other work, like particularly Asha and Anganwadi are used in other work, like if there is a census which is happening, so Ashas and Anganwadis are used. And if any activity is happening in the village, those people are involved. So that shifts the focus from the health and related issues. Okay, so these are the issues, and we identified what are the challenges. Then what is the way forward? The possible way forward, what I think is, ANM, ASHA, and Anganwadi is such a large workforce. It's very surprising that we don't have a dedicated human resource team. In an organization like a small one, also we have a dedicated HR way they manage and retrain and refresher training is done. But unfortunately, we don't have a dedicated HR team. I think that is very much essential, and they need supportive supervision and refresher training. With hands-on experience. I'm managing a large cluster randomized trial in central part of India, and we trained about 40 nurses with hands-on training in conducting deliveries and immediate neonatal care with all the dummies and on those simulation exercises, and they were very happy because they never had such an training. And when you give such a training, they feel motivated. I'm talking about the government nurses only. So, and they are giving better services after the training. So supportive supervision and refresher trainings are very much essential, and provide incentives when she does better, but don't penalize if she doesn't do anything. So that's one way of dealing the issues. And leveraging technology. Technology is the way forward. So I'll give you some examples how technology is being leveraged in India. I mentioned one of the challenges is she needs to carry a lot of registers and keep entering and summarize everything in another form with more than 200 indicators. So now we have a tab-based, paperless, real-time data entry where she need not carry all those 3-4 registers. She just needs to carry one tablet, which is almost being implemented in most of the India. And she'll be doing entry on the tablet. So that's one thing which reduces her workload, and she need not carry all those register whenever she's visiting a village. And the good thing is that this tab works offline. So it can be used in even in remote areas where there is no internet facility. And she need not have to fill another form with those indicators. So she just needs to enter the data. The indicators are automatically calculated and updated to the, she is doing it at the grassroots, so it will be automatically updated in the central server, which is there in the PHC. And with all this, it improves her efficiency so that she can concentrate more on her clinical services at the grassroots level. So this is one good thing which is happening. But it has its limitations. Again, there is no one to check whether she's entering the real data or she's just simply entering. Suppose she's, as I said, she's supposed to provide those 8 essential services when a pregnant woman comes. So we don't know whether she's providing or not. She's entering, we know, but we don't know.
Excuse me, sir. Your
Yes.
time, 2 minutes left.
Yeah, okay.
Thank you.
And another thing is electronic clinical decision support system. Yeah, the unknown or the ANM online is only for data entry, but we can add one more layer of technology where she can get support system. Suppose a pregnant woman has a hemoglobin of 7. The moment she enters 7, what should be the next action point would immediately come. So this is one layer additional. So it's integrated with tracking and referral services. And it's been tried in maternal child death in various trials on diabetes and hypertension that has been very successful. And it is done for both ANM and primary care physicians, where it helps to manage more and refer less. That's the main idea. And now we are using point of care testing. If you remember, we used to use Sally's method for hemoglobin estimation. It requires a lot of time. So now the point of care immediately on the spot result, small kits are available. All those things can be used. And nowadays we are also research level, we are exploring whether handheld devices for fetal monitoring can be used by the ANM. And this is better accuracy and immediate appropriate care. So I think that's it. So this is what I wanted to say, to give an overall idea and how it works, who are the key people and what they have achieved, what are the issues, and how this can be addressed, particularly using the technology. Thank you. Thank you so much for your patient hearing.
Okay, thank you. Give a plus for Dr. Sid. Yeah, I think it's very nice topic because you have National Rural Health Mission and also National Urban Health Mission, and I think it's effective to reduce the maternal mortality and also neonatal mortality. Okay, now we are going to the question section. The first question from Anisha Agrifina, student at University Negeri Medan. The question is, what is the specific role can a nutritionist play in create health people behavior?
Sorry, can you repeat?
What is the specific role can a nutritionist?
Oh, healthcare nutritionist. In
Yes.
public health sector, we don't have, as I said, it is mainly at the grassroots level. It is done by the Anganwadi worker and the ANM. So they have been trained, particularly the Anganwadi worker. She has that growth chart with her for under 5 kids. So she keep plotting that weight for age on that graph. And and it is so simplified that it has a color code, red, yellow, and green. So if the child is in the green zone, she need not worry. If it is yellow zone, it's an alert zone. If it is red zone, means she need to immediately refer. So this is about nutrition addressing the under 5. Whereas nutrition issues related to diabetes and hypertension, it is mainly the ANM who does the counseling. Yeah.
Okay, thank you. And the second question from Destin, you can direct to us. Him.
Thank you for the moderator. My question, I will introduce myself first. My name is Destin from the 8th semester Bachelor of Midwifery Institute Mitra Husada Medan. My question is, what the strategy did they do to improve the health status of poor, and did it work? The second question is whether the poverty rate is higher in the city or in the village. So are there different strategies in the city and in the village to improve their health status? Because I
Okay.
interesting for your material, sir. Thank you,
Okay.
sir.
If I understand, first question was, uh, sorry, can you repeat the first question? We'll go one by one.
Okay, sir. What the strategy did there to do to improve the health status of poor, and did it working?
Okay. So yeah, poor means, I mean, both in rural and urban areas. So for urban areas, they have come up with the National Urban Health Mission from 2013, and they have also started evening clinics. Usually A&M is there from 9 to 5, but in urban poor, most of the times the husband is working till evening. So if the public center is closed after that, he or she will be forced to go to private. Again, it will end up with expenditure. So now they have started evening clinics so that they can address all these issues. So again, the same basic level primary healthcare is given in urban poor setting. So that's how they are trying to address, and it is slowly showing improvement. I can see people are attending more and more evening clinics. And for urban rural poor people, it's always there. From 2005, the Rural Health Mission, A&M, and the medical officer at PHC, they are addressing. And your second question, birth rate in urban versus rural, right? Your second question was birth rate or health status in rural.
Okay, sir. I will repeat again. Is whether the poverty rate is higher in the city or in the village. So if difference, for example, if higher in the city, and then we have a different strategies, I think.
Yes, same thing in India also. There are particular issues which are common in urban. Like for instance, birth rate is probably more common in rural compared to the urban, but there is a lot of diversity, and maybe the vector-borne diseases are relatively more common in some parts of the rural area. But if there are some pockets like northeastern part of India where malaria is more common in urban area rather than rural. So yeah, there is a difference, but it varies from state to state. We cannot generalize which one is very common. Yeah.
Okay, thank you, Dr. Rashid. And then the next question from chat room, I will read. From Devita Purnamasari, student from Stikes Mitra Husada Medan. You have two systems, namely national rural and also national urban. So the question is, what is the challenge? I think you have explained the challenge for the system. Maybe you can explain.
Yeah, I can explain briefly. We heavily rely, for routine care, like which doesn't require emergency, like routine antenatal care, routine care of diabetes and hypertension. We heavily rely on A&M. And for mobilization, the community health link worker like ASHA. So these are the two key people, because doctor is not there everywhere. So if there is complication, then the doctor can manage. Otherwise, we heavily rely on A&M and ASHA. But the problem with A&M is quality of care is not up to the mark for the reasons, what qualitative research has revealed, like there is no proper training, supportive supervision, and unnecessary penalization, and lot of paper books, focusing on reporting rather than work. But now slowly we are trying to address all these issues, and so hopefully we'll see improvement in future.
Okay, thank you, sir. Maybe the last question from me. I think the national rural and urban health mission, I think, is good because the system effective to reduce the maternal and also neonatal mortality. But you say that despite this improvement, India lacks on SDGs, 2013. So what is the new strategy to maybe to complete the system?
Yeah, main thing is to fill the gaps, wherever there is a lack of human resources, they need to recruit, particularly A&M medical officer. That is the first thing. Second, focus on the quality, with the proper training and supportive supervision of the A&M, so that she can manage the routine things at the grassroots. What actually is happening is she is not properly managing. So the those pregnant women in the third trimester without early identification of the complication becoming more serious in the third trimester, and they are over referred to tertiary care center. That means tertiary care centers are overloaded. So that's why we see a lot of C-sections and related complications. So ideally, it should be less than 10%. C-section is in India, it's about 16 to 17%, which is much more than the WHO recommended level. So if we manage these routine cases at the grassroots, we will have less referrals, so that the tertiary care center can also function properly. So it's very much interlinked. So if you address one issue, the rest of the things will be taken care of.
Okay, thank you, sir. I'm sorry, because we have one question.
Yeah, please go ahead.
One question, because we have sometimes. So the question from Devi Marito, the student from Stikes Mitra Husada Medan. In your opinion, what is the most important obstacle for health workers in India, so that many health problems occur uncontrollably?
Okay, so main thing is, I mean, she is been going to the village and she has the confidence of the villagers, but main issue is lack of accountability and motivation. As I said, the supervision is mainly on checking the reports, what she enters, but not on what she delivers at the grassroots or the village level. So if the focus is on that, and if you can use technology to somehow make her more accountable, and somehow make her sure that somebody is observing, we can definitely see improvement in the quality. For instance, as I said, we can use the tablets, we can use the clinical decision support system, and we can also use the GPS system in the place. So she cannot simply enter the data wherever she wants. So she's not going to the village, entering in her subcenter only. With the help of GPS, we can locate where exactly the data is entered, whether it is entered in the village level or whether it is entered. You can help. And in our trial, we are also trying to see to put some checks. When she enters the data, she cannot straight away enter the hemoglobin or see the previous hemoglobin and straight away enter currently. Suppose the previous hemoglobin was 8, so she cannot write 8.2. She will not be able to see the previous record if you are using tab based. So that gives an that brings in transparency. So this is how we can use the technology and make them accountable and provide quality services.
Okay, thank you, sir. Because we have participant from Laos, and maybe you can ask direct from to Dr. Shit, please, Dr. Vinay.
Hello, my name is Dr. Phuvan Chanthavong from Laos. I'd like to ask you one question. As you mentioned earlier, you would avoid the penalty according to the lack of performance. So what will you do instead of improving the performance? What method will you do to avoid the penalty? Thank you.
Yeah, so penalty will, as I said, these penalties are imposed based on her reporting, what she writes on the paper, not actually what she does at the grassroots. So she will feel that nobody's worried what am I doing at the village level. I just need to finish the paper formality, right? So if you follow this format, you will get only data on paper. Everything is fine if you look at the paper, but when you visit village, nothing is happening, or she's doing whatever she feels. If she doesn't have time, or if she feels tired carrying those books, she will do only few, not all those 8 things or additional. So rather than penalizing her, we use positive deviance approach. That means if you do well, you'll be incentivized. Okay, if you don't do, you'll not get, you will not be penalized, but you'll not get the incentive. So if you use that positive deviance approach, that will motivate her to do better. And obviously use, as I said, technology, how to make her more accountable, how to make her realize that, everything can be tracked. So I cannot simply take anything for granted. And obviously it requires motivation and refresher training and hand holding. Yeah.
Okay, I think is it clear, yeah?
Okay,
Okay, thank you because the time is over. So thank you for Dr. Shit for your time and your sharing. And now give a applause for Dr. Shit.
Oh, thank you so much. Thanks for the opportunity.
Okay, thank you for all participants. I will back to Master of Ceremony.
Thank you for your time to the moderate. Now, giving the certificate as a keynote speaker to Mr. Dr. Sidaruda Sifali, MBBS, MD, London School of Hygiene and Tropical Medicine, London.
Thank you.
Madam Dr. Sutunawan Sinaga SKM MKS, time is yours.
Oh, thanks, Eddie, for receiving on my behalf. Thank you so much.
Giving the certificate to moderator to Mr. Edi Marjuang Purba MPH from Dr. Sitinderwan Sinaga SKM MKes. Well, that's all the third keynote speaker for today to Mr. Sid. Thank you for your time, and then nice to meet you in another time. You can leave our room. Thank you, sir.
Thank you so much. Bye-bye.
Okay, thank you for Mr. Edi Marjuang, who has the moderate in the third keynote speaker. And now we are entered to the break and lunchtime. So we can join again at the 2 p.m. Indonesia time. But before that, we take a picture. We take a picture in the Zoom. So I think to the participant to on camera. So we take the documentation first. The first slide. Sekali lagi kepada seluruh peserta untuk menghidupkan kamera atau membuat dalam mode on kamera agar kita mengambil dokumentasi. Sekali lagi kepada seluruh peserta yang masih meng-off-kan kamera untuk menghidupkan kameranya dalam posisi mode on. Okay, thank you.
Okay, that's all of our agenda for today, but we can join again in we can join to the fourth keynote speaker at 14 p.m. And we hope to all the audience from Indonesia or Laos or Malaysia or others country to join on time. Thank you.
Okay, good day. Assalamualaikum warahmatullahi wabarakatuh.